Hey, can you hear me, Hannah?
Yes, I'm trying to open up TJC's email right
Okay.
now on my phone so that I can copy the link
I can't
to
hear you.
our group message so everybody can see.
No,
You can't hear
I
me?
can't hear you.
Oh. Mm. Do you have it?
Uh, Hello, can you hear me?
Yes.
Okay. All right. So maybe now I got it. Maybe now I've got it right. Um, so now I can hear you. I know Chantel's trying to get on here. Um, can you guys not see my announcements on 009?
I haven't gotten any announcements besides the direct ones that you sent to, I believe there were 5 of us.
Uh-huh.
And that was a direct message, not an announcement. And so I'm taking the link right now and I'm going to post it in our group me, which has all of the PM students.
Yeah.
If you want to give it to tell the AM to do the same, and then they'll all be able to join with that.
Yeah, because I'm not sure what's going on with your 009 announcements then. Because that's the only way I can get in touch with all of you is via that way. Huh. Okay. Let me see if I can send it to Chantel. No, I sent it to all 5 of you, the link. So let me see if I can get Chantel on here.
Okay, I just sent a message out. I said Mrs. Patterson is holding a Zoom meeting right now for us to learn respiratory if anybody wants to join.
Try the link I sent so you can join. Where?
There we go, there's people.
Hey, you're starting to join? Try the link I
Yep.
sent you so you can join, send to day students for me. So do you guys have a 009 on your dashboard?
Yes, ma'am.
You do? Okay. Does it say summer or does it say spring?
It's summer.
It's summer? That's probably why, because I'm putting it on spring.
So it's 0090-I01.
Do you have a spring one?
No, ma'am. That one got erased from our.
That's why you're not seeing
canvas.
it. Okay. I don't have a summer
Okay.
one for you guys. That's the problem. Okay. I got to fix that tomorrow when I get there. Doggone it. I know there was a lot of people that wanted to join this too.
Well, I sent a message out to the PM group and everybody gets them. So hopefully more people will join. I see that.
I'll go ahead and get started with you. We'll get it recorded. We can always post this and they can start watching it. I'm going to have you do the same thing since I can't reach everybody. Is posted again on your guys' discussion board once I get the link, okay?
Okay.
To the recording.
Okay.
And hopefully, oh, look, it looks like some other people have joined in. Great. Can everybody hear me? It looks like you guys are all muted off. Do I have all of you muted or do you have yourselves muted? I'd like to hope everybody can hear me.
I have myself muted.
Okay. And so you guys are hearing me pretty good then?
Yes, ma'am.
Okay. I sent some notes to Hannah. Hannah, did you send those notes to them too?
I'm working on it right now.
Okay. Because you guys had over 200 PowerPoints that were sent to me to look at. I got them broken down to 25 pages here of notes to where I took out what I felt was important. And so you guys really need those notes to keep up with me. There's a couple of pictures. The other thing I had posted was a video on asthma. My husband and I created a 6-minute video along with some PowerPoints. So those are also posted on an old 009 posting. So I have to somehow get that to you guys too. I think I'll just email that to you, Hannah, since that seems to be working. And Chantel seems to be my day person that's sending stuff out. So that you guys can look at that, because I didn't write anything on asthma, because that video, and it's a YouTube video with a PowerPoint, and me and my husband acting out with an asthma child for that. And it's very explanatory about asthma. So I don't have any notes in my notes on asthma because of that. All right, so let's get this started. Do you guys have your regular PowerPoints too? I'll be referring to those somewhere around in there so that we make sure we kind of cover everything. Again, this is a review for your test on Wednesday. If I contradict what your professor says or what your book says throughout my notes or throughout what I am saying, you must go with what your teacher, your professor, your book says, not what I say, because this is just coming from me, not from your books or from your professor, since I don't know exactly what's on your test. So hopefully you guys have seen all of your lectures that you got on this, and you can just add whatever I've added to that. The last time I did this, a couple of students said that my notes were helpful. So you'll have these also, okay? So to begin with, we're going, chapter 29 deals with the anatomy and physiology of the respiratory system. I don't want to spend a whole lot of time in that because you don't usually get questions on anatomy and physiology. You're going to get questions mostly on all of those disease processes that you are learning when it comes to the respiratory system. So, but you need to know a little bit about how the respiratory system works so that you know what is abnormal. As you look in here, hopefully you guys have my notes. I have on the first page basically the upper airway, the lower airway, and what their job is for each one, beginning with the upper airway. And if you look at she's got some beautiful photos in her PowerPoints regarding all of these things. So make sure you're referring to the pictures. I've got a nasopharynx, oropharynx, laryngeal pharynx, paranasal sinuses, tonsils, adenoids, and trachea. What the upper airway does is it warms and filters all the air that we're breathing in before it gets into the lower respiratory tract. It can accomplish so that it can accomplish gas exchange and diffusion. The nasopharynx, oropharynx, and laryngeal pharynx is the main passageway for the air to pass through from the lungs, which filters, warms, and humidifies the air as it is inhaled. Air is moistened, warmed to body temperature, brought into contact with sensitive nerves. These nerves detect odors. Others provoke sneezing and expel irritating dust. So that's part of our immune system, our innate immune system that is helping us keep any bacteria or foreign objects from entering into the lower lungs, causing pneumonia or anything like that. Your internet connection is unstable. If I go out, I'm going to have to reconnect, guys, because I do have slow internet, okay? So don't leave me. Nasal mucosa traps practically all the dust and organisms in the inhaled air, and that's that cilia and mucus that is going around down that tract that helps do that for us. Sinuses function as serve as a resonating chamber for speech, and it is a common site of infection. That's where you get your sinus infections at, sinusitis. Pharynx, tonsils, and adenoids encircle the throat. We get tonsillitis, we get all of those sore throats, strep throat in the pharynx area. That's where all of those disease processes tend to start. These structures link the chains of lymph nodes, guarding the body from organisms that enter the nose. Again, that immune system working. Larynx is our voice box, also known as the watchdog for the lungs, helps with coughing, connects the pharynx with the trachea. Epiglottis covers the opening to the larynx during swallowing. The opening, the glottis is the opening between the vocal cords and the larynx, and she's got beautiful pictures of all of that in her PowerPoints. So take a look at some of that and just look at the photos and where things are at. The trachea is our windpipe passageway between the larynx and the bronchi via hilus, also known as the carina. Now the trachea can be part of the lower respiratory in some books, so whatever your book is telling you to put that trachea into, lower or upper airway. For the lower airways, we have the lungs, the pleura, the bronchial and alveolar structures needed for gas exchange. And this is where the gas exchange happens, is down in the lower respiratory. First, we have the lungs, right lobe with 3 lobes and the left with 2 lobes, enclosed in the thoracic cage around the top chest up here. We have a pleura, which is a serous membrane surrounding the lungs, which has a visceral and a parietal membrane. So in between that pleura, we have fluid, and that serves to lubricate the thorax and the lungs to help with smooth motion for the lungs during inspiration and expiration. So that helps keep it being able to constrict and not constrict and dilate a little bit. Left and right bronchus extend to the bronchioles, which have cilia, then extend to the terminal bronchioles. A transitional passageway between the conducting airways and the gas exchange airways. Alveoli, where oxygen and carbon dioxide exchange takes place. That is that little grape cluster that you see, and I got some great pictures on the next page as I get through here. Surfactant is made of the alveoli, and this reduces surface tension. This is what keeps that alveoli open. It gives it the ability to open and close. It is at this site where atelectasis begins, and it is the first step to pneumonia. Atelectasis is a disease process that we can stop as nurses from happening. We can immediately come in and tell our patients that are at high risk for getting atelectasis, hey, cough, deep breathe, use your incentive spirometer. Make sure that you're doing what needs to be done when you see a patient at risk for atelectasis. And we're going to go through who's at risk here when we get to atelectasis for us. And so that surfactant needs to be lubricating that alveoli so that it can open and close efficiently. There are macrophages within the alveoli that ingest foreign matter, and that's one of our white blood cells that is working for us. It's a granulocyte that has phagocytic abilities, and it will ingest any foreign matter getting into our lungs. It's just ready and on guard for anything that might be going through. Okay, so those are the structures of the respiratory system for you. And on my next page, if you guys have gotten and received my notes already, are a couple of pictures. The top picture is just a whole picture of everything we just talked about, and you can see where everything is at. The one picture down below that, the second picture, is a picture of the alveoli along with the capillary membranes. You cannot forget the fact that gas exchange has to happen between that capillary bed and the alveoli for it. And so we're going to talk a little bit more on how gas exchange happens now. For oxygen transport, our cells need energy that they can get from oxidation of carbs, fats, proteins. This process needs oxygen. So we eat, we pull all of this off from our carbs, our proteins, for that our cells to be able to have glucose to have energy. But they need oxygen to be able to do that. So this gas exchange is very important for that process. The process of oxidation produces CO2. So as it takes in the oxygen, it uses it up and it releases the waste product of CO2, carbon dioxide. So carbon dioxide needs to be exhaled out because it is a waste product. And that is how we get rid of our carbon dioxide. We don't pee it out or anything like that. The only way to get rid of CO2 is to exhale it out into the air. So if something goes wrong with our lungs, we can't get rid of our CO2, and we wind up going into what we call respiratory acidosis. which there are some disease process. We'll talk a little bit about that. Oxygen is supplied to the cells via circulating blood through the capillaries via diffusion, and that is diffusion. Basically, that word just means that it is a lower, wherever there's a lower gradient, then it can diffuse into that area to make it even again. For it, diffusion just is lower gradient to higher gradient. Once inside the cells, the mitochondria use it for cellular respiration. CO2 diffuses in the opposite direction from cell to blood. And I think we talk a little bit about it as you go in here, and I think your teacher has a PowerPoint in here regarding diffusion, on how it's diffused in and out of the air. Yeah, she does. On review of anatomy and physiology, continued on 4. She's got that diffusion picture in there. Respiration, there's 2 parts to breathing, okay? And both those parts have to work for you to be able to breathe correctly. And one of them is the chemical process. That's the gas exchange. That's the CO2 and the O2 exchanging in that alveoli and the capillary membranes. Then there's a ventilation part. The ventilation is the mechanical part. It has to open and close. Your chest has to open and close. You must be able to expand your lungs so that you can actually get air in. So respiration is the gas exchange part, okay, the chemical part of breathing. This is where gas exchange between the atmosphere air and the blood into the cells of the body happens. Oxygen concentration in the capillaries of the lungs is lower than in the alveoli. So it's able to go across. Because of this gradient, oxygen diffuses from alveoli to the blood, okay? And that's that diffusion process. And you guys don't need to get into depth with this. I'm just showing you guys that. Don't study this out. You're not going to get a question on it, okay? You just need to know that it works that way. CO2 has a higher concentration in the blood than in the alveoli, so it diffuses from the blood to the alveoli. Again, that lower gradient to higher gradient. The movement of air in and out of the airways replenishes the oxygen and removes the CO2. When you take a breath in, you're bringing in oxygen. When you take a breath out, you're breathing out CO2. And that is how we get rid of everything. And that's how our bodies stay in balance. Then we have the ventilation part, the second part, the mechanical part, the movement of the walls of the thoracic cage and of the diaphragm. Movements that increase and decrease the capacity of the chest, okay? Increased chest is inspiration. So when we breathe in, our chest inflates and it gets bigger for us so that we can fill it really good. And for that to happen, our lungs must have elastin, collagen, all of these things to make it work. The pleura needs to be nice and wet inside that middle to allow it to expand. When you have expiration, that's the decreased chest. That's where the diaphragm just relaxes, and now my chest is decreased, and that's expelling all of that air out. Chest wall and diaphragm become normal. Lungs recoil and force the air out. Inspiratory requires energy. That's about 1/3 of the respiratory cycle. Expiratory is about 2/3 of the respiratory cycle. So it takes longer to exhale than it does to inhale, basically. During inspiration, pressures are lower in the lungs and in the atmosphere, and that's just going a little too in depth for you guys. Let's go past that. Another thing that the lungs do is assist in control of acid-base balance. Okay, and you guys have already studied your acid base, I believe, and already been tested on it, and know that that's how we maintain our CO2 levels to keep our pH balance, by getting rid of it. Respiratory acidosis just basically means any disease process or any problem that happens to the ventilation, the mechanical part of breathing. Hypoventilation means that something's gone wrong with the mechanical part of my breathing, and I am not taking my deep breaths like I should for some reason in there. So when I don't ventilate, that means I'm retaining CO2. COPD is a good example of that. Emphysema, bronchitis, asthma, all of those winds up retaining CO2 and causing hypoventilation. Respiratory alkalosis is the opposite, meaning I'm hyperventilating. Now the mechanical part of my thing is just gone crazy and has increased, meaning I'm just getting rid of so much CO2, I'm going to be alkalytic if I don't care, no problem. A couple of issues are anxiety, when we hyperventilate with anxiety. Mountain climbing, when you get up into thin air that your body is not used to, you're going to get short of breath. Me, nowadays, just climbing upstairs will make me short of breath. And the more I get short of breath and I hyperventilate, the more alkalytic I'm going to be on there. Okay, so that's the acid-base part of it. The one thing that, and this next picture that I have on here, and I hope all of you have already gotten these notes to where you can see this picture. This has been the best picture that I have ever seen to show you the difference between ventilation and perfusion. There is something called a VQ mismatch, ventilation perfusion matching, okay? I must have enough blood and I must have enough air. Ventilation for air, perfusion is blood for oxygen to be carried through. So there must be that perfect matching of that for us to stay stable. But disease process happens, and there's 3 different ways that it can get blocked in our bodies. That first picture where it shows A, it shows perfect. That line going around the bottom is the capillary flow. You have your arterial side in the red and your venous side on the blue. And so that's unoxygenated blood going in and getting oxygenated. So as it passes that alveoli, that little round ball that's on that picture, that's the alveoli, okay? It's releasing CO2 out of the unoxygenated blood and receiving O2 and oxygenating the blood, and that blood's getting ready to go to the heart. So that is normal gas exchange and ventilation. And then if you look at B, it says blockage of the alveoli. Now the picture of my alveoli has shrunk. There's been some kind of disease process. Maybe I'm choking. I've got something in the way. Maybe I have a mucus plug in there that is keeping that alveoli from getting oxygen all the way to. So now all I have is perfusion. So my perfusion is high. I'm getting a whole lot of blood, but there's no oxygenation to that blood happening on there. So that's one way that that can happen. Then C, if you look over there, instead, now I have air trapping. And so now my alveoli has now gotten big and fat, and it's just increasing in size. And it's pushing up against that capillary membrane to where blood's no longer going through there. So now I have a perfusion problem because now gas exchange is not happening because it can't, because of the air trapping happening in that alveoli. And then the last way, blockage of the alveoli and blockage of the capillary for some reason. Maybe I have a clot in the capillary membranes going on, and maybe I have a mucus plug from bronchitis or asthma keeping my alveoli broken. So now I have both problems. I have a perfusion problem and I have a ventilation problem. Very dangerous. Usually they're intubated at this point. And so that winds up being a horrible process if that's happening to our patient in there. And so that has been the best picture I have seen to show us ventilation and perfusion. And then the next page just talks about that picture a little bit. Adequate gas exchange depends on an adequate ventilation perfusion ratio. VQ imbalances occurs as a result of inadequate ventilation, inadequate perfusion, or both. And that's what that picture is showing. The 4 possible states is normal for A. B means low, means a shunt has happened. Perfusion exceeds ventilation. I got all kinds of perfusion. This happens in these type of disease processes: pneumonia, atelectasis, tumor, or mucus plug. And if you look at that, those are all blocking my alveoli, not my capillary beds in there. C, that high, that dead space, ventilation exceeds perfusion, meaning I'm getting way too much air, but not enough blood. This happens with the pulmonary embolism, pulmonary infarction, or cardiogenic shock. For D, where it's absent, that silent unit, limited ventilation and perfusion, I've got both of those problems. I've got B and C, both of them going. That's going to be your pneumothorax, your severe acute respiratory distress syndrome. This is really bad. This needs to be taken care of. It's an emergency situation, and we got to get them air. And we'll talk about pneumothorax and acute respiratory distress syndrome, since that's one of your exemplars in their disease processes. Any abnormality of EQ will cause hypoxia. That's the biggest issue with our lungs. Hypoxia, hypoxemia, no oxygen. It leaves us very short of breath and hard to breathe. There's also a neurological control in there. So the nerves that is the phenoric nerve is one of the biggest ones that help control like the diaphragm and the lungs to expand. So if something happens to that phrenic nerve, now I have no ventilation. And so we're going to run into that hypoventilation problem with that. There are sometimes they'll go into surgeries and the surgeon may cut that phrenic nerve, and then that person is stuck on a ventilator for the rest of the time. Can one of you guys give me your email so I can share these notes? She's going over with you, then you can share the whole email. There you go. Perfect. Are you guys getting them?
I went ahead and did it. It's taken care of.
Okay.
Yes, ma'am. I took care of it.
Okay, good. Okay. I know I'm going kind of fast, but I'm just kind of going through this because I just want you guys to have an idea of how this works. Rhythm is controlled by the medulla oblongata, that's in the brain. The pons regulates the rate and depth of ventilation. So if I have any trauma to those areas of the brain, my respiratory is going to be damaged and I'm going to have trouble. Receptors in the medulla oblongata respond to an increase or decrease in the pH and convey a message to the lungs to change the depth and then the rate of ventilation to correct the imbalance. So if we are alkalytic, we are going to decrease our respirations. The brain is going to tell us, try to decrease our respirations. If we are acidic, then that part of the brain tells us, okay, increase your ventilation, increase your respirations so that we can get rid of some of the CO2. And that's where it's happening in the brain because it can sense our O2 and CO2 levels in there. The next picture, what is that showing? Our elderly considerations. It's always important because we deal more with elderly than we do with any age level. Elderly and little ones are usually the ones that are high risk for everything. But your professor goes into the elderly changes quite well. There's a picture of the difference between normal and age-related changes. You need to keep that in consideration with every disease process that you're looking at. For the older adult, they're always at risk for aspiration and infections related to bronchi and alveoli become enlarged. They start growing, and you can see that picture there. Decreased surface area due to enlargement of the alveoli. And when I say decreased surface area, if you look at the normal alveoli and all of those little round grape-like clusters in there, there's all this surface around there when they're perfectly round that the capillary beds will surround it. And then if you look at the one that's not, you can see that there's not as much pretty grape-like clusters there. And so there's not enough surface area for blood exchange to happen, the capillary beds to happen for that. So decreased surface area. Reduced working cilia. The cilia becomes damaged throughout life. If they're a smoker, they don't even have any cilia. So that is an immune problem for them. So they don't even have the ability to start coughing. Decreased cough reflex. They have a hard time giving that good cough, that good from the gut cough. And so that is what's needed to get rid of a bunch of bacteria out of the lungs. In the elderly, they can't do that as well. Calcification of cartilages, meaning they're not going to have enough elastin to cause that expansion of the chest. And so they don't take deep breaths. So the lower, when you listen to a lot of elderly's lower lobes, you barely hear any gas exchange known as diminished lung sounds. And so that happens a lot with them, and that just opens them up and puts them at risk for infections, pneumonias. And this is why we want them having their vaccines. Decreased chest wall compliance due to decreased elastin, and that's exactly what I was just talking about. People who are at risk of getting problems in their lungs, of course, number one is going to be smoking. Smoking always causes issues in the lungs. I don't care, you may go many, many years. My mother was one who started smoking at 16. She didn't start having issues until she was 72. Some people, it might hit them at the age of 30 if they're smokers. Depends on the genetic makeup. But it does eventually do some kind of damage to the lungs. Number one, if you smoke, you have no cilia, period. And so you don't have that ability to grasp any small bacteria and cough it out for you. That's the biggest issue with that. And then all of a sudden it just puts you at risk for cancer, pneumonias, and any things like that. Exposure to secondhand smoke always is a thing that we ask our patients about because that puts them at risk for possible problems. My mother-in-law died of lung cancer. She never smoked a day in her life, but her husband smoked. So she got it from secondhand exposure. Personal or family history of lung disease, depending on the type of lung disease, like cancer is not inherited, but cystic fibrosis is inherited. So we're going to be asking them, do they have any history of that? Genetic makeup, like I said, it depends on the genetics of people on whether or not they're going to get affected early on or later on in life. Exposure to allergens and environmental pollens, for them, that always causes issues for people, especially if they're asthmatic. It causes mucus plugs, decreases gas exchange, makes them short of breath. Dietary factors, if they're malnutritioned and not getting out their vitamins and minerals that they need to keep everything working the way it's supposed to. HIV, overcrowding, and poor immunizations also puts them at risk for all of these disease processes in the lungs. Overcrowding is a problem right now with this coronavirus. If you live in a very impact like the dorms, this is why they're not opening up the dorms, because overcrowding just causes more breathing on people and causes a lot of infections. Atypical immune response, maybe you have an autoimmune disorder or you're immunosuppressed due to a transplant there. So allergies to food, environment, or drugs can cause a problem. So let me see if I can get everybody's here. Atypical immune response, allergies to food, environment, or drugs are also at risk for that. Now here's where you're going to get questions, your assessment. Okay, it's nice to know the risk factors of who's going to have lung problems, but here's where you really need to get really good at. Because even though you may not know something about the disease they're asking you about, if you can do a really good assessment and assess your patient and know what to do and understand the concept of breathing, then you can answer your questions a little bit easier and by using your common sense because you know what needs to happen. So here's just a bunch of questions to begin for the health history that comes into that. What type of symptoms are you experiencing is the first thing. You need to let them explain to you how they're feeling, what it is their thought process is doing so you can help explain to them what's going on. Then do you have a family history or respiratory disease? Because if they have a family history of some type of disease process, then it may possibly be inherited. What medications are you on? So we need to know, are they using inhalers? Are they using PO medications that are helping them? Are they on steroids? That's a big one with respiratory issues. Steroids are a big deal. A lot of these people with respiratory issues are on steroids, and that causes a lot of side effects for them. So we want to know what type of medications they are on. Any history of respiratory problems themselves? Do they have COPD? Do they have asthma? Do they have anything that tells you ahead of time that you need to be looking for this? Are you short of breath at rest, with activity, or both? Maybe they're just short of breath when they're walking, or maybe they're short of breath at rest and walking. So we need to find out where it is that is, because if they have both, then they're going to be worse. They're worse off than what they usually than somebody who just has shortness of breath with activity. Do you have any chest pain when breathing? This is called pleuritic pain. If they hold their breath, then that pain might go away, telling you that it's pleuritic, okay? True chest pain, if you hold your breath, isn't going to go away. So that makes it's going to be cardiac problems versus respiratory problems. Are you a smoker or around anyone that smokes? That just makes sense. If they are a smoker, how many packs a day do you smoke? Are you coughing? And if you are, is there anything coming up with that coughing? If something is coming up, what color and consistency is the sputum? Is it clear? Is it thick? Is it thick in yellow or green? Telling us maybe a possible infection down there. Because if it's clear, then we just need to get that up before it does become infected. Where do you work? This will tell us a lot if they're inhaling chemicals. We need to know where they work. Does the respiratory problem they're having interfere with their work? Does it interfere with their daily living? Where do they live? Are they homeless and they're stuck in the environment? To making respiratory disease processes even worse. So we need to know where they live, or maybe they live in an overcrowded area somewhere. What is their diet like? Malnutrition causes a lot of problems, so we need to know how they're eating. Or maybe they're just having a lack of appetite during this process that we might be able to help them out with some Ensure or something. Does your respiratory problem affect your activity of daily living? If it does, then we need to make them more independent. How are we going to do that? Have you had the flu or pneumonia vaccines? We need to understand that we need them having these vaccines if they're at risk for respiratory problems, no matter what their age. Find out if they snore at night. If they don't know, maybe their partner knows. Might be at risk for sleep apnea, which we'll talk about. Do you seem to need daytime naps to get through your day? If so, another clue as to possible sleep apnea problems. Those are just questions as you're asking them. Now you want to go into a physical assessment here, using all of your senses, your vision, your smell, your touch. All senses will help you do your physical assessment. First of all, you're always going to inspect. You're looking at their skin color. Is it gray, bluish tint to their lips or fingertips or pale? You're always looking at their work of breathing. Are they using accessory muscles, their shoulders, their neck to breathe, their chest? Are they using their abdomen to breathe? Is it going in and out really bad? Is it labored? That's what we call labored breathing. Or maybe it's unlabored and they're just short of breath. What is their respiratory rate? Is it normal? Is it increased or is it decreased? We need to know both for them, because if it's increased, then they're not getting gas exchange. If it's decreased, they're not getting ventilation. So we need to know both. Is exhalation prolonged? Are they having a hard time and they're having to use their pursed lips to breathe out? And how prolonged is it? Is the patient apprehensive or anxious? Meaning, are they feeling that air hunger? I don't have enough air, and I'm telling you, they get pretty apprehensive and anxious at that point. Are you looking at the symmetry of their breathing? Is the chest wall on both right and left coming up and down at the same time? Or are they on opposites? Telling you that there might be something wrong with their rib cage. Can the patient complete a sentence when talking? These people that are very short of breath with respiratory problems can't even get 2 or 3 words out without having to take in a deep breath, stop, take a break, then finish their sentence. Is there clubbing of the fingers present? Any chronic respiratory patient is always going to have some clubbing on their fingers when you look at them. Any short-term or memory loss, a lack of oxygen over time is going to cause memory problems, and it is going to cause confusion. What is the patient's current activity level? We're asking them about their daily living. What is their gait like when they're walking? Are they dizzy when they walk? Does the patient have peripheral edema, extended neck veins? In other words, is their blood not perfusing their lungs and now it's out causing edema? Inspect placement of the trachea, because this can cause problems with the trachea. Pneumothorax, trachea moves away from the affected side. That's when you're going to see that, and it's going to move away. So if I'm affected on the right, it's going to move towards the left. Do they have a musculoskeletal abnormality? such as a barrel chest or maybe kyphosis. The barrel chest you're usually going to see on a patient that has COPD, emphysema. Kyphosis is that lumbar one where they have like a hump on their back for them. Using your pen light, you're going to look inside their nasal passages, their oral mucosa, making sure they don't have any sores inside their mouth. Is their mucus dry? Looking at all of that. And does the patient have any bad breath at that time, telling you there might be some bacteria back there causing some issues? What sounds are you hearing with your ears as you're talking to them? Are they wheezing? Do they have stridor? If they have stridor, that is usually an emergency situation that you need to get fixed right away. Auscultate all lung fields, comparing your left to your right sounds as you listen to that. So it's not only just taking your stethoscope and putting it on their lungs, but it's also hearing, seeing, feeling to tell you a lot about your patient. And you can, after you get really good at that, you can do it very quickly. Breath sounds. She has a definition of them in her thing, crackles, and I just kind of wrote out a little bit there as your definition, coarse, discontinuous popping sounds. The best thing to get good at listening to breath sounds is find YouTube videos and just start listening to them. But if she asks you questions on your test, you need to understand that if she asks you, where would you hear stridor? What type of disease process? She's going to give you 4 disease processes, and you need to know when you would hear stridor. You know, pleurisy, you're going to hear a friction rub. For stridor, it's going to be an asthmatic that's in bad shape right now, at their worst. So knowing what sound you're going to hear coarse crackles when you have possibly pneumonia, anything wet in there, emphysema or bronchitis, you might hear coarse crackles. Fine crackles is more about atelectasis, okay? Atelectasis is the biggest thing that tells you about fine crackles. If you rub your hair against your ear, you're going to be able to hear what that's going to sound like on your lungs. Wheezes, they can be deep and low. The low-pitched rumbling sounds heard primarily during expiration. That usually happens with bronchitis and bronchiectasis. That is, bronchiectasis is one of your disease process along with bronchitis. But bronchiectasis also is what we call RSV for our babies in there. So that's what our babies get. Continuous, musical, high-pitched whistle-like sounds during inspiration and expiration. Here's your asthmatic patient and the buildup of secretions or bronchospasms. Your friction rub, harsh crackling sound like 2 pieces of leather being rubbed together, heard during inspiration alone or during both inspiration and expiration. May subside when that patient holds their breath. Coughing will not clear the sound. This is called a pleural fluid problem. A pleural rub will do that. So something's going on with the pleura when you hear this friction rub. So it makes it very hard to expand the lungs. Diminished, no to very little airflow sounds. This is what you hear in COPD or just in elderly lungs in general that aren't getting around and taking those deep breaths. Absent, I mean, no sounds. This is bad. Pneumothorax or collapsed lung here. And so we need to get a chest tube in this patient to get that lung inflated again. And this is all over that one side, absent all the way up to bottom, not just on the bottom there. That's causing that collapsed lung. Different tests that she has written for you, CBC. This is going to evaluate your patient's immune system, looking at the WBCs mostly, but if they do a differential, they actually tell you how many neutrophils, lymphocytes in each one of those WBCs come out. But this tells you if there is a bacterial infection or a viral infection happening to your patient. Evaluates oxygen carrying capacity. So it also, the CBC looks at their red blood cells, your H&H, which is hemoglobin and hematocrit, for any possibility of anemia or bleeding, which will make your patient short of breath because they don't have enough oxygen carrying capacity. That is what carries your oxygen to the different tissues, is the red blood cells. Evaluates platelets needed for clotting, arterial blood gases. See if I can get my picture. It's not which evaluates your acid base by looking at your CO2, bicarb, pH balances. It also evaluates your oxygen, which is what we're going to look a lot at on all of these different disease processes, is the PaO2. This is how much how much oxygen is in your blood. And this is what causes hypoxemia or respiratory distress. And so we will run an ABG to find out if you are in respiratory distress. D-dimer is a fibrinogen test to check for pulmonary clots or PE. If it's elevated, we're going to send that patient to a CTA afterward to find out if they have a pulmonary embolism. Culture and sensitivity is needed to evaluate types of bacteria, what antibiotic will kill that specific bacteria. To get that, we might need to gather a sputum sample, which is very hard to do. Oxygen saturation, that's our pulse oximetry, when we pulse ox on our fingers and we're checking our saturation. Capnography is to evaluate CO2 levels. If elevated, acidosis due to hypoventilation. Diagnostics for us. So sometimes they'll check that, not very often. In California, we used to have to put a capnography on our PCA pumps when our patients were self-administering their morphine or their Dilaudid for that. But here in Texas, I don't see them quite often, maybe possibly in the ICUs to just check how bad their acidosis is. Chest x-ray, that's always a good one. That tells us if our patient has pneumonia. Infiltrates means pneumonia. Collapsed lungs, it shows us that. Cardiomegaly is the size of the heart. It also shows us the structures of the alveoli and the bronchi. Ask your patient to remove any metal or jewelry before going. They need to be able to hold their breath. Can be done as a portable in their room, which is what happens most of the time. Another one is the CT, the computed tomography. This gives us a better view of lung tissues or any abnormality such as tumors or pulmonary embolisms, clots that are growing in there. Contrast is usually used unless contraindicated due to renal insufficiency. If your patient has renal insufficiency, meaning their BUN and creatinine are elevated, then they are not going to get the contrast. They're going to get the CT just without the contrast. Administer anti-anxiety medications if your patient is claustrophobic. If contrast used, patient NPO for at least 4 hours beforehand. Assess allergies for iodine or shellfish if they're going in there. So those are things that you would need to do as a nurse before sending them in there. You need to find out also if they're on metformin so that they can hold that for 48 hours afterward. The next test is a ventilation perfusion scan. This evaluates the blood flow and how the blood is flowing through the lungs. Done if the patient is unable to use contrast dye for a CT scan. They prefer the VQ over the CT scan if you have renal insufficiency. Tell patient to avoid caffeine, alcohol, and tobacco for 24 hours prior. This may interfere with some of the isotopes that is going on with that they give the patient. Pulmonary function tests. This is done usually when the patient is well, not when they're sick. We need to know what their best lung capacities are. This evaluates their lung capacities. This is where they teach you about tidal volume, inspiratory force, minute volume, and vital capacity on all of these. And you'll just have to look at a chart for complete totals, but I've never seen a test where any teacher tests you on exact on those, just that they are part of the pulmonary function test. Done to determine extent of disease, response to therapy, and screening tests for those that work in potentially hazardous industries for them. Pulmonary angiography is your next test. This basically is looking at the arteries and veins of the lungs. Fluoroscopic procedure to evaluate pulmonary arteries. Assess allergies to iodine. Keep them NPO 6 to 8 hours prior to the test. Administer anti-anxiety meds if needed. Explain patient may feel a warm flushing sensation or chest pain during the injection of the dye. After procedure, you want to monitor your vitals, your level of conscious and vascular access site. assess neurovascular status often. And that's checking pulses and make sure that they are not cool to the touch afterward, especially after that, right below the IV that they inserted all of that stuff through. Bronchoscopy, if you guys have any questions or I'm going too fast, slow me down, okay? It's just, this is a lot of information in this little time. Bronchoscopy, direct inspection and examination of the bronchi through a flexible fiber optic scope, can take a tissue sample, sputum sample for diagnosis, can remove any foreign object, control bleeding, destroy and excise lesions, or provide brachytherapy. Brachytherapy is a type of radiation that they do for patients with cancer. Oxygen devices, you need to understand these and how you would use them. The nasal cannula is the first thing we put people on. You can have up to 1 to 6 liters of oxygen given to them. Make sure that if you're using 4 or more, that you are humidifying that air. Otherwise, it really dries out the nasal passages and can cause some nosebleeds. So make sure you're humidifying that air. It is a low flow type of oxygen device. The simple mask, you can go all the way up to 8, anywhere from 5 to 8. Also a low flow device for them. Just remember that you have to take it off for feedings. Just make sure you put a nasal cannula on them when you do that. Partial rebreather mask, you can have up from anywhere from 8 to 11 liters of low flow. Must not collapse the bag underneath during inhalation, so you're going to add just some air down there to keep that inflated. A non-rebreather, 10 to 15 low, and she's got photos on the PowerPoints of all of these that are really good photos. So make sure you take a look at those and understand when you can use each one. 10 to 15 liters. If you are on a non-rebreather, if your patient is on a non-rebreather, you really don't want them on that for very long. This is just almost like a rescue type thing, trying to prevent them from going to be intubated. We do put them on the floor on a non-rebreather when they get really bad, but we are monitoring them to get them off of it as soon as possible. We don't want them on that for very long. Venturi mask, high flow would be your next step. This here gives you a more perfect type of oxygenation, and you can keep track of how much oxygen they're getting. Because remember, in the air, we only have so much oxygen in the air, and then nitrogen and other little parts of stuff. So those low flow oxygen devices aren't giving you 100% oxygen. A Venturi mask will give you 100% oxygen. And so you have a little more control of how much they're getting. Transtracheal catheter surgical procedure for chronic oxygen needs. They'll put something in the trachea area and trying to get them oxygen in below that area. CPAP and BiPAP is used often. If they are on a non-rebreather for very long, they will try them on BiPAP next to try and get their CO2 levels down. Most of the time, they have very, very high CO2 levels when we're putting them on BiPAP. And so BiPAP is one of the best ones for that. CPAP is used for sleep apnea and for just some simple breathing problems, but BiPAP is used a lot more nowadays on the floor to decrease CO2 levels. That's the last step before getting intubated, and they're using the BiPAP on you. Tracheostomy, that means they're actually got a hole in the trachea area to where you're breathing through the trachea because you can't seem to get something is clogging the upper airway. It's swollen or something. Endotracheal tube, that's actually putting a tube all the way through the mouth to open up your trachea down through the trachea. Medications that will be used for any respiratory problems are nebulizers and inhalers with spacers. I am going to post to Hannah a video of how to use some of these inhalers during the asthma for that she can post on the website for you guys. Go ahead.
Can you hear me?
Yes.
Okay. I had a couple questions. So the difference between CPAP, BiPAP is BiPAP, they're both, ooh, okay. The BiPAP has ventilation, right?
Mhm.
So that's the only difference. CPAP doesn't have
Well,
ventilation.
CPAP is
And then
ventilation
BiPAP's easier to
too.
control,
What
right?
CPAP is doing is just pushing air in to keep the trachea open. Okay? That's all it's doing. What BiPAP does is it allows it to breathe in and breathe out. So that's the bi-level. Okay? CPAP is just a continuous
So like
flow of
assisted
air
ventilation.
going in for ventilation because it's used for obstructive sleep apnea. If I have obstructive sleep apnea, meaning something is obstructing me from breathing, okay, then what this continuous flow does on the CPAP is keep that obstruction open. Maybe I have loose cartilage or something that keeps it open there. And so it will just push air continuously, keeping me to be able to ventilate. So they both deal with ventilation, okay? But one of them just deals with keeping you open to breathe, where the second one allows you air to go in, and then a second part of it is that it allows air to come out. CPAP doesn't allow the air to come out. You do that on your own with CPAP.
Okay.
So
Okay.
they both deal with
And then
ventilation
for a
and gas
tracheostomy.
exchange. Say that again.
Okay. For a tracheostomy, so they have the inflation cuff, and then you're supposed to deflate that every now and then to prevent sores.
Yep.
And then that's also whenever they use their speaking valves.
Mhm.
So is there a certain period whenever they have to have that inflated again to where they won't be able to use their speaking valve, or is it possible to just leave it out?
I don't
Like,
know a
why is
lot
that
about
there if
tracheas,
it's
but
not?
you can leave it out. But I don't see those used quite as often, at least not on the floor. All I see are regular trachs without that balloon there so that they can still
Mhm.
speak and they can still do that. So I don't know a whole lot about the balloon itself. Okay. For that.
Okay. I didn't know if all of them.
Yeah. And again, I can't see them asking you stuff like that. You guys are
I
going to
just
have
like
to
to know.
base it. Yeah. You're going to have to base it off of your previous test. How deep did she really get? Okay. On those tests.
Compared to like what I already knew, not as deep.
Yeah, it's not this deep. So it's just knowing your basic stuff. Nasal cannula, simple mass. You know, at what point do I need to go to the next step? When do I want to go from nasal cannula to a rebreather? Okay. At what point in my patient's disease process for us? But when you get into trachs and endotracheal tubes, that's ICU stuff. I mean, even RNs don't even have to know that. Okay. Breathing exercises, this is what you do need to do for your patients all the time. The goal is to exhale completely and empty the lungs completely by breathing more slowly by prolonging the exhalation time. Instead of spirometer, provide a visual for the patient. That's what it does. It helps inflate the lungs to prevent and treat atelectasis, especially beneficial after surgery or prolonged immobilization. If you have a patient that comes in with a hip fracture, they better have an IS, because guess what? They're not going to get out of bed for several days. It takes less than 24 hours for atelectasis to set in. And if they are not coughing and deep breathing, then get them that IS and make them do that. Control their pain, because if they're under pain, they're not going to deep breathe and they're going to have atelectasis. And the next step, they're going to have pneumonia very quickly. And so we as nurses need to be aware that that needs to happen. Okay. So incentive spirometer, educate your patient on how to use that. So anybody after surgery that's had anesthesia, this is wonderful stuff for them to do that, because we have put them to sleep. Everything has been put to sleep. So we got to wake it up, and deep breathing and cough is the best way to do that. And so that's what that incentive spirometer does for them, is to get them to do that. For the first little while after surgery, they might be on oxygen. The goal is to get them off that oxygen, and to get them off of that, that incentive spirometer will do that. A flutter valve is a new little gadget thing that they have patients using to improve their cough, especially for your elderly that have a bad cough. They just have to blow through that, and then it causes them to give them a bigger cough. Of course, the exercise of deep breathing and coughing, diaphragmatic breathing, pursed lip breathing, all of those will help your patient breathe better. The goal of diaphragmatic and pursed lip breathing is to exhale. We need to get all that air that is being trapped down at the bottom of their alveoli out. And this is how we get them to get it out, by prolonging their exhale with that pursed lip breathing and that diaphragmatic breathing. Chest physiotherapy includes postural drainage, chest percussion, and vibration. This is where we can either lay them on their stomach over a wedge, and we can, I call it pounding, but it's not really pounding, but cupping our hands and then kind of pressing on their chest, like beating on a little bit of a drum, to push things up, starting from the base of the lungs and working your way up. And we are trying to pull some of that drainage out of them that they're having a hard time getting out. So we just percuss their chest or their back, whatever works for them. Goal is to remove bronchial secretions, improve ventilation, and increase the efficiency of respiratory muscles. And so that was everything that I could pull out of chapter 29. Now we're going to go into chapter 30 here. Anybody have any questions about chapter 29? That is just A and P, basically. It gives you anatomy, physiology. The biggest things you want to concentrate is your assessment, the different types of breathing, the breathing exercises. I can see test questions coming out of those three areas very easily for you. And so you need to understand those. Chapter 30 begins with some disease processes, and mostly of the upper airways on here. Epistaxis was her first one. Basically, that's a nosebleed, rupture of tiny distended vessels in the mucous membrane. Risk factors include people who have dry, cracked mucous membrane. So think about your patient on oxygen that is dry for them. Anybody who's had any trauma could be at risk for nosebleeds. Hypertension, because of those hypertension, especially if it's uncontrolled, can break one of those vessels inside the nose, causing nosebleeds. Hemophilia, this is a person that doesn't clot very easily, so they wind up bleeding from different orifices. Medications can put you at risk for having nosebleeds. Inhaled steroids makes you dry and crack mucous membranes there. Inhaling cocaine, if your patient is doing that. So those can do that. Thrombocytopenia, you don't have enough platelets to clot, so you're going to bleed for it. Use of aspirin. Aspirin is an anti-platelet, decreasing my platelets from aggregating so I can clot. So anything that's going to keep you from clotting is going to cause you to bleed. And so you're going to possibly have nosebleeds with that. Liver disease. Liver disease is where we make our clotting factors. Liver is where we make our clotting factors, sorry. So we're not, if we have disease of the liver like cirrhosis, we aren't clotting very well because we're not making our clotting factors. And then of course, local infections. If we get a nasal infection up there, sinus infection sometimes will cause that also. So those are all the people that might be at risk. Anybody underneath one of those categories, when you do their health history, you're going to suspect the possibility of epistaxis can happen. How do we take care of this patient? This is where you're going to find your questions. You need to sit upright with head tilted forward to prevent swallowing and aspiration of blood. If they are bleeding a lot, their tendency is to want to swallow it back. And this causes aspiration very easily. So our goal is to sit them upright, head tilted forward, to prevent that swallowing and aspiration. You're going to pinch the soft outer portion of the nose way up on top there for at least 5 to 10 minutes of direct pressure, and hopefully that'll stop it. If that doesn't, we're going to place some ice on the nose because ice is cold and it causes vasoconstriction. And hopefully that might do it. It might be necessary to administer vasoconstrictors such as phenylephrine spray. So they will spray that up there to see if they can kind of stop that bleeding with that by constricting those vessels. Some people use a cotton tampon as a plug up in there to stop that bleeding, because then that puts some pressure in there also for them. May need to suction nasal passages to inspect their nasal passage if it's really bad, so you can kind of see what the heck's going on in there. May be packed with gauze, impregnated with petroleum jelly or antibiotic ointment. A nasal balloon can be used. That's when it's really bad, is when they're going to blow a balloon in there to try and put some direct pressure on those vessels that are causing the bleeding. If unable to control with above interventions, then electrocautery may be done. They can cauterize with either silver nitrate or using a high frequency electrical current. Basically, they're burning off those vessels so that they can just stop bleeding. Monitor vital signs during this process. Provide tissues in an emesis basin in case it causes them to throw up. Once bleeding is controlled, educate the patient to avoid vigorous exercise for several days. Educate to avoid spicy foods and tobacco. Any forceful nose blowing, straining, high altitudes, or nasal trauma. Try to provide them with adequate humidification to the air, so a humidifier in the room would be great. And when to seek medical attention, you need to educate them on. That's what you're going to be able to do as a nurse for anybody that has those problems of epistaxis. Your next disease process is nasal polyps and deviated septum, which causes obstruction of the nasal passages. So a deviated septum means that the middle inner part that separates both nostrils is crooked, basically. Polyps are little balls of things hanging down inside there that are not good. They obstruct the nasal passageway and you cannot get air in through the nose. They wind up being mouth breathers. Nursing management includes head of the bed elevated to promote drainage and alleviate swelling. Don't keep them supine. Get them up some into a semi-Fowler's position so that they can get that drainage going down. Report any excessive swallowing, could be hemorrhaging and swallowing blood. If you walk in and you see that throat just going, just with some good gulps all the time, you're going to want to inspect that. Include frequent oral hygiene to decrease dryness. Educate to avoid blowing the nose with force. Educate signs and symptoms of bleeding and infection. Educate not to use any type of anticoagulants, aspirin, postoperatively, because they're going to go in with those polyps and that deviated septum surgically and remove that or fix the deviated septum or remove the polyps. Educate to avoid activities that increase pressure, such as bending over at a 90-degree, vacuuming, sports, anything that might increase the pressure, because we don't want them bleeding after surgery. Sinusitis is an inflammation of the nasal cavity. Nasal congestion due to inflammation, edema, transudation of fluid secondary to an upper respiratory infection. Pain, pressure, fullness over the sinus along with a fever sometimes can begin due to allergies or a bacteria. Nursing interventions, antibiotic if patient has a true bacterial infection diagnosis. If it's a true bacteria. Nasal saline lavage, I don't know if some of you heard of those neti pots. Some people use that to clear out their mucus and it reduces inflammation for us. Decongestants such as guaifenesin or pseudoephedrine. This is just a mixture of Mucinex and Sudafed, or a decongestant nasal spray, or it can be an oral pill to help them. Intranasal steroids to reduce inflammation. And that's just a spray that goes up to the nose. Educate to use warm compresses to relieve any pressure that they might be feeling. They can have acetaminophen or ibuprofen for pain. Educate to avoid swimming, diving, and air travel during this infection because the pressure causes a lot more pain. Educate on potential complications such as fever, severe headaches, and nuchal rigidity. That's neck pain and its stiffness. We really want to call the MD if they start having those types of issues, because then they might have what we call meningitis. Your next big disease process that you guys have in here, or exemplar, is obstructive sleep apnea. A lot of people have this. Risk factors are obesity, just because it causes collapse of the trachea, a high palate in their mouth. They might have a receded mandible, meaning that bone that's right underneath your lips here gets receded in and causes the inability to breathe through there. Smoking, definitely. Male gender, it happens more with males than females, although nowadays I'm seeing both genders having it really bad. Postmenopausal women will have it. Advanced age, just because of the structural changes. Anything that causes any structural change that causes the collapsibility of the upper airway. So this could be trauma even to that thing and cause this sleep apnea. Basically, the pathophysiology of this is the repetitive apneic events resulting in hypoxia and hypercapnia. So basically, they stop breathing. So if you stop breathing, you're retaining CO2, makes you hypercapnic there, and you're not getting enough oxygen in, makes you hypoxic. So you really become short of breath, and this is what makes you fatigued because now you're slightly anemic at this point. This triggers the sympathetic response. Heart rate goes up, and all of a sudden these people wake up with a big snort. And if you ever hear anybody with sleep apnea, those snores and that snort is them waking up from a apneic event. The consequences, if this does not get taken care of with CPAP, hypertension, risk for an MI, a heart attack, or even a stroke. Diabetes, these will cause all of these problems just because they can't breathe at night. So they really need a sleep study done. Signs and symptoms, you're going to start seeing excessive daytime sleepiness with chronic fatigue. They're always tired. They get woke up several times throughout the night from this snort and inability to breathe. Might even cause some insomnia. I don't see that as much as I do the nocturnal awakening. Loud snoring with breathing sensation for 10 seconds or longer for at least 5 episodes per hour. This is one of the criteria for even being diagnosed. Followed by awakening abruptly with the loud snort as the blood oxygen level drops. You're going to wind up with morning headaches due to the lack of oxygen and the increase in CO2. Intellectual deterioration, you lose memory and attention during that time. Personality changes, you might be irritable. Impotence, systemic hypertension, dysrhythmias, it can even cause heart problems like AFib. Pulmonary hypertension, cor pulmonale, which is right-sided heart failure. Polycythemia is an increase in red blood cells because we're not getting oxygen. Those red blood cells say, okay, let me make you some more red blood cells. So you wind up making polycythemia from there. Enuresis, maybe even bedwetting might happen. That's severe though if that happens. Diagnosed by nocturnal polysomnography, sleep study, which is the definitive test. The polysomnography is usually done as a outpatient in a sleep study wherever they do them overnight. You sleep and they attach EEG electrodes to the brain, an EKG to the heart, and then they monitor you throughout the night to find out what's going on. Although nowadays this can be done at home without the EEG, and they can kind of monitor your heart with the heart rate. Nowadays is they put a little monitor on your chest just below the breast area, kind of where the xiphoid process is. And then you wear a nasal cannula that's attached to that. And it keeps track of your CO2, your O2, your heart rate, and and lets the people know, and it kind of records it and sends the information to the doctor's office. So nowadays, most of the time they're doing it at home to find out if you have sleep apnea. Medical management. If we lose weight, we might be able to get rid of this. A nasal patch sometimes helps them open up their sinuses if that's where their obstruction is. Avoidance of alcohol and sedatives would be good for these people because if you sedate them to the point where they don't wake up from the way they're breathing, then they might not wake up at all. Positional therapy prevents sleeping on their back. That makes it worse. A CPAP, which prevents collapse of the airway by pushing air into the nose and or mouth, depending on what type of mask that they're using. A BiPAP for severe COPD patients that need oxygen along with control of CO2. Keeps from getting encephalopathy due to severe acidosis. So this is helping them release a lot of that CO2 that they're retaining during the night. Surgery can be done to mean, if they do go surgery, these are things you want to do as a nurse. Maintain semi-Fowler's position, use ice for swelling. Take stool softeners to avoid pressure of having a BM. Avoid any activity that may increase pressure for you. And that's sleep apnea. So then she goes into infectious disorders. These are true either fungal or bacterial, viral infections that can happen to the respiratory system. Let's see, all the itises, and I just put them in one group because they fall into the same category, guys. Anything that ends in itis are inflammations of that specific area. Rhinitis, sinus infection, or the common cold. Pharyngitis, that's your strep throat. Laryngitis is the voice box infection. Tonsillitis, infection, inflammation of the tonsils. If caused by a bacteria, it is an infection. Signs and symptoms of any of those itises is general malaise, just feeling achy and horrible all over. Chills, headache, and muscle aches, maybe even fever if it's true bacterial infection. To manage all of this is symptomatic therapy, basically. We need to let it run its course, especially if it's virus. Now, if it's a bacteria, we can give them an antibiotic, but most of the time it's mostly viral. Give them adequate fluids. They need to be drinking lots of fluids, increasing that. Rest, prevention of chills, and use of expectorants like guaifenesin, that's Mucinex, and NSAIDs for pain. It also decreases inflammation for NSAIDs. Antihistamines for any nasal congestion, such as sneezing and rhinorrhea. That's just nose drip, nasal congestion. If evidence of bacterial invasion, then we're going to give them some antibiotics. But we really need to look at this and prevent overuse of antibiotics. So if it's viral, then we're just going to give them stuff for their symptoms. Different viruses she added to her list was influenza, West Nile, avian flu, severe acute respiratory syndrome, swine flu. These are different viruses which cause the patient to be very, very ill. These are bad ones. Antivirals need to be started immediately along with any symptomatic care needed. They're hard to cure. I've had patients with West Nile virus. Influenza, when it's really bad, is really hard on the patient. I've never seen anybody with avian flu. I have seen severe acute respiratory syndrome. And I've never seen anyone with a swine flu, but underneath this category, every one of these are bad. They are not good. And it takes them a while to get over, especially if it's an elderly person. West Nile virus, I have seen encephalopathy with them to where their level of consciousness is very decreased, altered mental status, all the way to the point of unable to speak at all. For you. So she just had them as a category as viruses in there. So that's how I kept it. But they really need to start their antivirals right away as soon as they get diagnosed with one of these. The next thing she has is cancer of the larynx. Our risk factors for cancer of the larynx, and that's our voice box now. We're not going to be able to talk. Tobacco, alcohol and tobacco combined. If they are using that, asbestos, if they're breathing in asbestos, secondhand smoke, paint fumes, wood dust, cement dust, chemicals such as ammonia, tar products, leather and metals, any nutritional deficiencies, genetic predisposition is inherited, more common in men, and it's really prevalent in African Americans and Caucasians. And then it happens a lot to the weakened immune system. So those that are immunosuppressed, those are all your people that you're looking at that might have the possibility of getting larynx cancer. Signs and symptoms. This is where you might get questions because you need to know what your patient's going to look like to be able to diagnose them. Hoarseness more than 2 weeks. Change in their voice. It becomes harsh or raspy and lower in pitch. They have a persistent cough. Sore throat that's burning. Airway obstruction, difficulty breathing, dysphagia, difficulty eating, pain, and then foul breath for them. So look at those signs and symptoms and kind of put those together. There's so many disease processes for this test that you guys are really going to have to use your common sense when you come to these signs and symptoms to be able to put them together. To diagnose larynx cancer, they're going to use a laryngoscope to go in to visualize the area to see what they see on those cells, see if they see a mass or just the cell, abnormal cells. A CT scan looking for any masses. An MRI is going to look for the same thing. Biopsy would be your definitive diagnosis. So when they have that laryngoscope down there, they can take and pull a piece of the tissue to do that. If they find diagnosis of larynx cancer, these are the treatments that are available to them. Radiation, where it eradicates the cancer and preserves the function of the larynx. Excellent results for the early stage. There, we're going to monitor their skin because radiation directly on the skin causes some issues. So we want to be careful with that. Chemotherapy, this has its own little mess there. If they're on chemotherapy, then you're looking more so as a nurse to help them through the nausea and vomiting end of that. And then maybe some psych issues if they lose their hair with the chemotherapy. Laryngectomy, this is where they actually take the larynx out. You've got a great photo in your PowerPoint slides looking at that, how they do that. You're going to need some speech therapy for methods of communication, such as writing, lip speaking or reading. Communication boards can get an artificial larynx if needed, and how to use that. You're going to educate them how to use that. Educate on tracheostomy care for them, because they're going to have a tracheostomy for a while until that heals, and then possibly they can pull that out for them. So that is cancer. Not good. Not a good one to have. Lower respiratory disorders. This is now going into chapter 31 here. What else can I tell you? I can't think of anything else on the chapter 30. Do you guys have any questions? Are you guys doing all right? I am going to post this, so if you guys need to leave or go and come, so please do. I will send this to Hannah for her to get it on your guys' webpage once it comes to me as a recording. Bronchiostasis is your first one. Did you have a question? Anybody? No? Okay. Bronchiostasis, the pathophysiology for this is chronic infections which cause the loss of supportive structures and resulting in thick sputum that ultimately obstructs the bronchi. And that's what bronchiostasis is. It's just the mucus plug. The sputum is the most horrible part of this. They just can't breathe. Think about your infants with this. Their airway is so small as it is. You plug it up like that, it makes it difficult for oxygenation. It impairs mucociliary clearance, so that ciliary and the mucus that is part of our immune system now is not working quite as well to get it out because of this thick sputum that's in there. Can cause lung abscess, which drains exudate onto the bronchi. If it gets that bad, if they stay obstructed that bad, bacteria just start eating away, causing a more abscess on the bronchi itself, and then it starts draining all that pus and causes even more problems. Alveoli are blocked and collapse. This causes that ventilation perfusion mismatch, VQ mismatch that we talked about earlier. The inflammatory process causes scarring or fibrosis in the lung tissue, making it unable to work. Can be caused from cystic fibrosis, asthma, or TB also. Remember, anytime you have any respiratory problems, especially once you start getting into this lower respiratory disorders, such as bronchiectasis, if you have it as a chronic problem, you are causing lung scarring on your lung tissue. Once you scar that tissue, it no longer works for us. So that means that gas exchange has now decreased in that area. The more you have it, the more scar tissue you're going to have, and it's going to be harder and harder to breathe as you get older. Signs and symptoms are chronic cough, production of purulent sputum in large amounts, lots of it, hemoptysis, meaning bleeding when they're coughing up blood, clubbing of the fingers if it's chronic, okay? You don't see clubbing of the fingers if it's every once in a while that you get it, but only if it's chronic. Crackles and wheezes because it's just a fluid, a mucus plug, and the air's trying to get through and out of it. So you're going to hear that crackles as they're trying to breathe. Wheezes if it's gotten really worse. That means the inflammation inside the bronchi has now narrowed the airway to the point where I'm wheezing. And so we really need to get them some bronchodilators at that point. Anorexia causes a lack of appetite. You don't feel like eating when you can't breathe. So anorexia, dyspnea, shortness of breath, which is very painful and can cause some pleuritic pain for them. Repeated pulmonary infections, if they are constantly getting infected in some reason, they're making this plugs, this thick sputum, putting them into bronchiectasis. Diagnosis is done by its symptoms. A prolonged history of productive chronic cough with sputum consistently negative for TB. These people do not have TB, even though they may sound like it. They do not have TB, and their test results show that they don't have TB. The CT scan reveals bronchial dilation, meaning that the bronchus are now inflamed and dilating. From them. How do we treat bronchiectasis? Best thing is to get rid of the secretions. We might have to use some chest physiotherapy where we're cupping and compressing on the lungs, postural drainage, so they can lean forward, possibly on a wedge or something like that to see if it can come out by gravity. Bronchoscopy, removal of the sputum. They can go in there and just pull it out if it's really bad. If they're a smoker, they really need to stop smoking. So make sure you know how to educate a person on how to stop smoking for this test, because that's what respiratory system is a big one. Antibiotics for any infection if present. If that sputum is yellow-green and they're showing temperature, elevated white blood cells, they're going to put them on an antibiotic at that point, because now we have a bacterial infection that has gone in and caused this, that's decided to creep in. Mucolytics and expectorants, that's your guaifenesin for you. Bronchodilators, which is the albuterol, and this is an inhaler, rescue inhaler, or it can be nebulizer to give this to your patient. Oxygen if needed. If their O2 sats are below 92%, they definitely need some oxygen. Vaccines for flu and pneumonia, we're going to monitor them on that one, especially with your elderly, especially if they're getting consistent problems with this. We want to make sure those vaccines are in place. A surgical intervention if it's pretty severe, a lobectomy if secretions are unable to be controlled, and a pneumonectomy. Pneumonectomy means they're taking out the entire lung. A lobectomy means they're taking out just one of the lobes that are causing the problem. Pneumonia, pathophysiology for pneumonia is inflammation of the lung, which causes infection. Exudate winds up being built up inside the bottom of the lungs, causing like a fluid in there. Causes include bacteria, fungi, or viruses. So if it's a viral pneumonia, it's got to run its course, and we're just treating them symptomatically. Fungi, we can put them on an antifungal. If it is a fungi pneumonia, those are difficult to treat. And so you see a lot of people with HIV having the fungi pneumonia. Bacterial, we see a lot of pneumonias with, so they definitely need an antibiotic. Arises from usually normal flora present in patients whose resistance is down. If we are very workaholics and we get too tired and our resistance and our immune system is tired, then we wind up getting that also. Inflammation can occur in the alveoli, producing exudate that interferes with gas exchange. So their O2 sets wind up going down. Secretions and edema cause partial occlusion of bronchi or alveoli, decreasing gas exchange. Can cause hypoxemia due to the VQ mismatch, shunt due to lack of ventilation, decreasing oxygenation in blood. Basically, all those sentences mean is that they're not getting enough oxygen in and their O2 sets are dropping. There's 4 different types that get spoken about. HAP, hospital acquired. This usually occurs 48 hours after hospital admission. Community acquired, occurring in the community during the first 48 hours after admitting. So if it shows up within that first 48 hours that they're admitted, they got it from the community, not the hospital. HCAP, I can't remember what the difference was between that and that one, occurring in non-hospitalized patient with extensive healthcare contacts. So us nurses that are around the healthcare, or maybe they have comorbidity, patients have comorbidities that keeps them in around the healthcare setting for some reason. So your SNF patient, resident of a skilled nursing facility, would get this type, healthcare acquired pneumonia. Antibiotic therapy, chemotherapy, immunosuppressive patient can get this. Difficult to treat. It's usually a multi-drug resistant bacteria that is causing this type of pneumonia. Ventilator associated pneumonia. This is a patient on a ventilator, and this happens quite a bit if care is not taken, occurring 48 hours after being ventilated. They're starting to monitor these pneumonias to find out new ways of caring for them to prevent this pneumonia from happening. And then there's aspiration pneumonia, of course, aspiration of bacteria that normally live in the upper airway, whether through food, saliva, however it is being aspirated. So those are the different types of pneumonias that can occur. Our risk factors, those that are at risk for getting any type of pneumonia, anybody with chronic lung disease, of course. If you have cancer, smoking, COPD, any disease process that have chronic secretions of mucus, bronchitis, asthma, cystic fibrosis, all of those have mucuses that cause a bunch of issues for patients. So they're always at risk for pneumonias. The immunocompromised patient, their WBCs are so low that they can't even fight off any type of infection. And pneumonia is one of those ones that actually kills our immunocompromised patients. So we got to be very careful with them and put them in neutropenic precautions if we see that they are in the hospital to help prevent any pneumonia from happening. Smoker, decreased ciliary action because they've killed their cilia. Prolonged immobility or shallow breathing pattern. This is your patient that comes in with your fractures, comes in with different wounds that need to be healed, and they're not getting up and getting out of bed. They're not rolling over. They're not moving. They will get pneumonia, and it won't take long. They didn't come with it, but within 48 hours, they might have pneumonia if we are not moving them, if we are not making them do deep breathing and coughing, if we are not making them use their IS as nurses, and that is on us. for those patients. So we need to know that that patient that becomes immobile is at high risk for getting pneumonia, and we need to do the prevention end of that to prevent that from happening. Sometimes your patient's not cooperative, but you do the best that you can. Maybe they have a depressed cough reflex. This would be your elderly again, so they can't cough up anything, any sputum that might have got caught there, and so they wind up getting pneumonia. Any patient that has a nasal gastric tube or an endotracheal tube is at high risk for aspiration pneumonias. So we need to monitor them and keep their head of the bed up at least 30 degrees or more to prevent them from getting their pneumonia. Supine positioning in patients unable to protect their airway. It's not very good for them to be laying straight flat on their back. This is why those beds move, getting them up a little bit. Antibiotic therapy. If they're on antibiotics, we're killing all of their good flora that we even have. Not only the bad flora, but their good flora, which increases their risk for other infections. Maybe they're getting an antibiotic for diverticulitis, which is a DI problem there. But we've also killed their flora, decreasing their immune system also. And so now they've got pneumonia on top of that. So anybody on antibiotic therapy, especially prolonged antibiotic therapy. Alcohol intoxication, they're just immune system and malnutrition, so they're going to get it because of that. General anesthesia, sedatives, opioids, which causes shallow breathing. Anything that decreases my ventilation is going to give me pneumonia eventually if I don't fix that ventilation problem. Anesthesia, because I'm coming right out of anesthesia, I am asleep, and we've put everything to sleep, so we got to wake it up. Here, give them that IS, wake them up. Advanced age, just because things aren't working as well, we don't have enough elastin in our lungs, we don't have things to keep ventilation going increased, and you can just remember that PowerPoint from the first on the advanced age on the elderly. Respiratory therapy with uncleaned equipment. A lot of our patients use the CPAP machines, they use inhalers, they use all of this stuff at home. If they do not keep it clean, this is why it's very important if our patients are on any type of inhaler to make sure they are rinsing out their mouth afterward. If they're using nebulizer treatments, they need to rinse out their mouth and do oral care right afterward because that bacteria is an opportunistic bacteria that will cause pneumonia on them. They need to be taught how to clean their CPAP machines constantly to keep that and prevent bacteria from building up. And people who are around healthcare workers a lot, possible contact transmission if it is one that we can pass it on. Viruses, we can usually pass it on. Prevention. This is the biggest thing about pneumonia. Pneumonia is a high risk for our elderly. We want to prevent it as much as we can. So how can we prevent it? Remember, nurses do a couple of things. We do everything we can to prevent a disease process from happening. We do a lot of education, and we start with the least restrictive way of doing that. So when you're going to answer questions, make sure you know how to prevent it, and you know the least restrictive way to help them from getting worse and causing a complication, because those are going to be your answers most of the time. Prevention, pneumococcal influenza vaccination are a must. Promote coughing and expectorating of the secretions, helping encourage them to give a good deep cough. Use the diaphragm to push it up. For immunocompromised, let's put them in neutropenic precautions and be careful that we're following those. Shutting that door, making sure we're all gowned up before we enter, and no sick people coming in to visit that patient. No plants in the room, no water just sitting there over an hour where bacteria can grow. No raw vegetables or fruit in the room. All of those things we need to monitor for our neutropenic patient that's immunocompromised. Encourage cessation of smoking, reposition immobile patients frequently and promote lung expansion. This is using your NSAID spirometer, deep breathing, coughing, of course. Those are key with respiratory, guys. If you don't get at least one question on something like that, then I don't know. Provide frequent oral hygiene. Keep the head of the bed up at 30 degrees. What are you going to do first? If they ask you on the question, are you going to raise the head of the bed, or are you going to put the nasal cannula on and give them oxygen? Well, the first thing you're going to do is raise the head of the bed. That's the first thing you do immediately. And then the second thing, grab that nasal cannula and put it on, because you might not have one in the room and you have to go get it. So that might take you a little bit longer to go get, even though you're going to be probably in real life putting this on doing this at the same time. But the head of the bed always comes up. Make sure the head of the bed is up on your patients that are at risk for aspiration with NG tubes and endotracheal tubes. Monitor patients on antibiotic therapy for signs and symptoms of pneumonia, just as a secondary infection. Monitor the respiration rate and depth of breathing, especially if they're post-op or on opioid analgesics for respiratory depression. If they are on opioid analgesics and they're taking Norcos, they're taking morphine, they're taking Dilaudid, Demerol, all of those will cause respiratory depression. So before we give them that, we want to know their respiratory rate. Is it above 12? And if it is, then we're okay. If it's not, I ain't giving it. We're not going to give that. When they come out of surgery, their analgesics, they're usually on still 2 liters of oxygen because they're not ventilating very well. They're not taking in those deep breaths. So the sooner we give them that IS, the better off they'll be for that. So those patients, we want to help prevent any pneumonia. Because as long as we're not deep breathing, then those little bacteria like to take over in that bottom of that lung and cause pneumonia. Make sure any respiratory treatment equipment stays clean. They like to leave it in a bag in the back of the bed back there. Make sure it stays in the back of that bed and that patient hasn't dropped it on the floor. If it's fallen on the floor, then go get a new one for the respiratory therapist. Don't just pick it up and put it back in the bag. Use strict hand hygiene to prevent transmission from one patient to another. So that's on us so that we can keep that from spreading. So no different ways to prevent pneumonia from happening. Signs and symptoms of pneumonia, and anything in yellow in here is something I've either gotten off of your PowerPoint from your teacher, or I felt that it was something you could get a question on. So I highlighted those areas. Headache, low-grade fever, pleuritic pain, myalgia, so body aches, rash, pharyngitis, a sore throat, mucopurulent, meaning yellow-greenish, sputum, cheeks, flush, lips, and nail bed, cyanosis. Now, this is a late sign. You seldom see this in pneumonia unless it's so severe that it causes cyanosis. That's the blue tinge of the nail beds and the lips for you. Shortness of breath.
I hate to interrupt you, but
Go ahead, Kayuda. Did you have a question?
ours is not, well, the paper I have isn't highlighted.
Your paper isn't highlighted? It doesn't have yellow
No,
highlights on it? On the signs and symptoms?
No, it doesn't.
Okay, I'll send another
No.
No,
copy.
ma'am, they do not.
I'll send another copy to Hannah that has those highlights on it, okay? That she can pass out with this
Okay.
Video once I get it sent to her, and see if it shows up with the highlights on it.
I'll
Alright.
email it to the AM group.
Hannah, did your copy
Okay.
have highlights?
No, ma'am, but once you send it to me, I'll send an email to Kianda.
Okay. I'll see
Alright,
what happens to
thanks.
the highlights to that. So what I have highlighted here is the low-grade fever, pleuritic pain, myalgia, mucopurulent sputum, the shortness of breath, orthopnea, dyspnea, crackles, wheezes upon auscultation, and the yellow rust-colored sputum is what I have highlighted under the signs and symptoms. So those are the biggest things that I can see questions coming from on there. And if you start seeing yellow rust-colored sputum, this is not a good sign. This is end of life sign that they are really not doing well for that. So we need to prevent it from getting that far. Crackles, wheezes upon auscultation. The other thing I will tell you about pneumonia is it's one of the highest risk for sepsis. Always monitor any patient with a UTI and pneumonia for sepsis, because you see it more and more often now putting them into sepsis. Make sure blood cultures have been done before you start any antibiotic. For the elderly, which I highlighted also, lethargy and confusion are very, very key, because those might be the only signs and symptoms you see on an elderly patient. They normally don't get fevers. They might get the headache, but they don't get fevers. For your elderly, the confusion is key. Restlessness, they're restless and they're poking and pinching at stuff or pulling stuff off. Maybe they wear a nasal cannula and you see them pulling that off. Those are keys that something's wrong. They're not getting oxygen for some reason, not enough. And so you're going to look at pneumonia being one of your key problems there for them. How do we diagnose this? Key gold standard chest x-ray, positive for pulmonary infiltrates and or consolidation. When you see those two words, I got pneumonia, when you read your reports. Blood and sputum cultures before the antibiotic begins. This is checking the blood cultures to check to see if they are septic, okay, or if they're going septic. The sputum culture is to find out what type of bacteria this patient has, so that we can put them on the right antibiotic. We're going to start them on a broad spectrum until the sensitivity comes back from this culture. Sputum cultures are really hard to get. So this is the steps that I found for trying to get a good sputum culture. You're going to rinse the mouth with water to minimize contamination by normal flora. You're going to have them breathe deeply several times and then cough as deep as they can and expectorate the raised sputum into a sterile container. So hopefully you get actual sputum and not just saliva in that sterile container. A bronchoscopy can be used to obtain the sputum sample if necessary. Most of the time we don't go that far. If we get it, we get it. If we don't, we don't. We just keep giving them broad spectrum antibiotics for that. Complications that can happen is pleurisy, inflammation of the pleura. This gives you this sharp stabbing pain when the patient breathes, might go away when they hold their breath. When you listen with your stethoscope, you might hear a friction rub for that. That is key to pleurisy when you hear that friction rub. And again, that sounds like leather coming against each other when you hear it inside there. Pleural effusions is another complication. This is more fluid accumulating in that pleural space. You can see it on a chest x-ray. This is when they start doing their thoracentesis to remove some of that fluid. And this is inserting a needle into that pleural sac, allowing all that fluid to drain out into a jar. My mother-in-law did this a couple of times before she died to help her breathe better. And they can take out liters. They took out 3 liters every time, full of fluid in that pleural sac. Think about 3 liters of fluid, okay? That's 3 big IV bags of fluid surrounding the lung. I can't ventilate that. So you're not getting air in. It's just squeezing that lung because it can't ventilate with all that fluid inside that pleural space. Once it's relieved through a thoracentesis, then they can breathe again because now they can ventilate. Now the lungs can expand. They don't have anything squeezing it with that fluid. Complications can be empyema, which is purulent drainage. This is infection in there. Sometimes if it's severe enough, they will put a chest tube in to drain that empyema out of that lung, that pleural space for them. The other one, of course, sepsis, the spread of bacteria into the blood. Pneumonia is one of the highest risk diagnoses for sepsis. And then, of course, respiratory failure. At respiratory failure, we're probably going to intubate this patient. And we'll talk a little bit more at the end regarding respiratory failure. How do we treat pneumonias? Antibiotics is the biggest thing if it's bacterial, antivirals if it's viral, usually IV or oral. If they're in the hospital, they're getting it IV. And eventually we'll put them on oral. Expectorants and bronchodilators. Expectorants to get them to cough up the mucus. Bronchodilators to open up the bronchioles for them to be able to breathe. Oxygen, of course, because they're hypoxic, so they're usually going to be on oxygen initially, hopefully titrating them off in a couple of days so that they're not completely on that, or getting them back to their baseline oxygen levels that they need to be on if they use it at home as home-dependent oxygen. Increase fluids. That is an answer to almost all kinds of questions. It's least invasive. Make your patient drink for you, because if I increase fluids on these patients that have a mucus problem, it's going to thin that mucus down enough, hopefully, for them to be able to cough it up and decrease that pneumonia for them. So you might get a question regarding increasing fluids. So that's pneumonia. For your TB, tuberculosis, we don't see as many cases here anymore, although I guess in other lands we do. The pathophysiology, and I didn't go into too much of a depth of it, but closely associated with poverty, malnutrition, overcrowding, substandard housing, and inadequate health care. And all of those, just if you think about it just a little bit, you can see poverty because they don't have enough money to stay nutrition-wise, falls under that malnutrition area. And also they're usually living in an overcrowding area where contact is very easy to get once one person has it. Substandard housing, tuberculosis might be around to where they are inhaling some of the droplets. Inadequate health care, they're not around enough to even know to go to the doctor, so they're just spreading it. Transmitted from person to person by airborne transmission. The droplets are usually 1 to 5 centimeters in diameter. An infected person coughs, sneezes, or taunts, releasing these droplets into the air. The larger droplets fall, but the smaller droplets remain in the air, and those are the ones that are inhaled, causing infection. Transmitted into the alveoli and deposited, and then they just begin to multiply. The immune system responds with inflammation and phagocytosis. Lymphocytes destroy the bacilli and create an exudate. Remember that neutrophils are the first there, and we already have macrophages doing their job. Neutrophils will kill one bacteria, then die off, and that is what is causing that exudate. It's that white pussy stuff that you see at the end of wounds because of them dying, are dead white blood cells. And so that exudate now is an area of bacterial growth also, if it stays there. So they need to get rid of that part of it. So it causes worsening of the symptoms. Granulomas are tubercle. These are just like, I call them cocoons type thing, created inside the lungs. They are new masses of live and dead bacilli surrounded by macrophages, which form a protective wall. And they become dormant at that point once they're inside that protective wall. And so you might not have signs and symptoms of TB, but it can show up later in life. Can go to other parts of the body via lymphatic system and blood. Infection occurs 2 to 10 days after exposure. Can activate if patient is immunocompromised at some point throughout their life for some reason. Usually about 10% of people are actually infected with TB, which isn't a huge amount, but it is a bad one to try and get rid of. Risk factors, people who are at risk for getting TB are those in close contact with someone infected, immunocompromised status, elderly on steroid therapy, transplant patients, substance abuse, IV injection use, any person without adequate health care, pre-existing medical conditions like diabetes, chronic kidney disease, cancer, or HIV. These guys are always at risk for TB. HIV especially. That one's a bad one. Immigration from or recent travel to countries with high prevalence of TB, such as Southeast Asia, Africa, Latin America, Caribbean. Your person who's institutionalized, like a skilled nursing facility, used to be state hospitals also. I think we still have a few of those around. That TB can be a risk factor in there. Living in overcrowded substandard housing, being a healthcare worker performing high-risk activities such as respiratory therapy. Those people are really at high risk because they're giving them nebulizers, which causes them to cough And then there goes those droplets. So make sure you're wearing the appropriate PPE for airborne transmission. And you might, for this question, for TB, they might even give you what would be the appropriate PPE for you. Do I need just a regular mask or an N95 mask? I need an N95 mask, right? So make sure you know what you really need to be wearing for this. Prevention of transmission. So now let's prevent from getting it ourselves or from other people from getting it. First, early detection. You need to find out as soon as possible if the patient has TB. Initiate airborne precautions. This means placing them in a negative pressure room. There are special rooms in the hospitals that have an ante room, which is a room outside the bedroom itself where the patient is it. And that is where you do all your masking and unmasking and cleaning up afterward before entering and exiting the room. Make sure you're using an N95 mask, not just a regular mask. You don't need those droplets to go in off the sides. These are specially made to prevent airborne problems. Do routine TB testings. This is why the healthcare, anybody going into any type of healthcare has to do yearly TB tests. Ooh, speaking of which, it's time for me to do mine. And keeping track of those to find out. Signs and symptoms of this would be low-grade fever, cough, night sweats, fatigue, weight loss, blood-tinged sputum, chest pain, late sign. For the elderly, altered mental status, possibly delayed reaction from the skin test, and needing a second test. So be careful of that with your elderly. The biggest ones, if you want to highlight now, would be the night sweats, the cough, and the weight loss. Those are early signs. The blood-tinged sputum now is late sign. So along with that chest pain. How do we diagnose it? Positive TB skin test. Chest x-ray can reveal lesions in the upper lobes. Sputum culture. If you have received the BCG vaccine, and there's a lot of people in all those different countries that have received that vaccine already. And so if they do just the skin test, they're going to immediately come out positive because they already have the antibodies and antigen that they have been given to prevent them from getting TB. So they have to do the chest x-ray or they do these two blood tests that can be done now for them, the quantiferin TB gold and the T-spot. And these are just blood tests for them. Treatment is anti-TB medications. They like to ask questions about INH, rifampin, and pyrazimide. That fourth one, I've never heard of. I doubt that you get a whole question on that, but they really like to ask questions about those three drugs. Isoniazid, liver, all of these you need to watch the liver for. So you're going to look at liver enzymes, okay? AST, ALT, your bilirubin, anything like that, alkaline phosphate. Those are all liver enzymes that you monitor. So liver function tests. Avoid foods with tyramine, and those are things like tuna, aged cheese, red wine, soy sauce. I see that question all the time, all the time. What type of foods do you need to avoid there? Red wine, soy sauce, aged cheese, tuna, salami, any dried meats, smoked meats, anything like that has tyramine in it. They need to avoid that while taking this medication. It can cause headaches, flushing, hypotension, palpitations, and diaphoresis. So it can be really detrimental to them. They need to take this on an empty stomach. So we're going to educate them on that. Rifampin, we need to educate them that it turns their urine orange. That's the question they like to ask on this one. Monitor, of course, liver enzymes. This does interfere with a few medications, interferes with beta blockers, oral anticoagulants, digoxin, steroids, antidiabetics, and contraceptives. So if the patient is already on one of those medications, this drug is strong enough to really interfere with those. So we might have to monitor them or even change up a few things while they're on this medication for the 6 months that they're on it. Again, take on the empty stomach. Pyrazimide, Again, we're going to monitor their liver enzymes, and this one increases uric acid. So gout, we want to monitor them for possible gout. Ethambutol, monitor vision, caution with renal disease patients for them. Is the only thing I saw in there that was really important. But all of these patients have to be on all of that together. I've seen mostly on the first 3 patients on all 3 of those. They must have it for 6 months, possibly even 12 months if they cannot get a TB test, a normal TB test. I don't know if I wrote, you have to have at least two normal TB tests within a certain amount of time to be able to come off of this medication and say that you were cleared from your TB. Nursing management, what are we going to do for our patients when we get them in the hospital? Of course, they're in that negative pressure room. We're going to promote hydration and secretion expectorant because they are going to be coughing. They're going to need to get rid of that mucus plug and they need to get rid of it. Just make sure that if you're in there and they're doing that, that you are gowned up and have your N95 mask on. Airborne precautions doesn't necessarily mean you have to have a gown because it has to be inhaled for you to contract the disease process. So when you look at airborne, it says just the mask itself, but I'm putting a gown on, I'm putting gloves on, and I ain't going in there without it for me. So I would just do that. Promote hydration and secretion, position to facilitate airway drainage. So maybe some postural drainage, helping them to be able to alleviate themselves of that. Educate the patient on adherence to take it. They got to take these meds. There is no ifs, ands, or buts. There are people on house arrest and monitored on house arrest to try and get these people to take their medications and prevent the spread of TB. Instruct on hygiene measures, cover their cough, proper disposal of any tissue they may have used, hand hygiene, lots of hand hygiene. Your teacher this time in a lot of her PowerPoints is using a lot of nursing diagnoses in there. She even went as far as describing what falls under a bunch of these. Look at the impaired gas exchange, look at ineffective airway clearance, and ineffective breathing pattern. Those are the 3 they like to ask questions about, especially the impaired gas exchange. Anybody with a respiratory problem has impaired gas exchange. And so you're going to see decreased O2 sets. You're going to see possibly a fever, things like that. And she's got a whole list under, especially that first one, impaired gas exchange, that you guys really want to know. So look at that slide. Know that slide for impaired gas exchange. I don't think she probably asks a whole lot of nursing diagnoses on these tests, but something tells me for the respiratory system that impaired gas exchange is going to come up, period. So I would know those nursing diagnoses for that test and understand them. How would you use those? Pleurisy, and I already spoke of pleurisy above, so I just wrote a complication of pleurisy is pneumonia on there. Basically, we're going to treat the underlying condition causing the problem and pain for it. Pleural effusion, again, I wrote about that above in the other thing, and we talked a little bit about that. Complications of it are pneumonia. Another complication, it can cause the collapse of the lung, causing a pneumothorax in which a chest tube is placed. And we're going to monitor this patient with an effusion for absent lung sound. She's got some great photos too. You guys, her photos in those PowerPoints are really good to look at and use them if you're a visual person to help you and put that together in here. Auscultate lung sounds, maybe diminished or absent. Signs and symptoms of dyspnea, pain, cough, increased respirations. Diagnosed by chest x-ray. Thoracentesis can be formed to pull out that fluid. Treat underlying cause. What caused that pleural effusion? Was it a pneumonia? Was it an infection? Was it a virus? What is it that gave them that pleurisy or that pleural effusion? So we need to treat their underlying cause. And then we go into pulmonary fibrosis. That was cystic fibrosis. For some reason, I thought that was supposed to be cystic. I'll have to look at that on my notes when I go back. Pathophysiology, this is restrictive lung disease. When you see the word fibrosis on anything, it means you have restricted that, whatever it is. Here, it's the lungs. And usually it's progressive. It gets worse and worse and worse, and you do not survive from it. Typical patient is older adults with history of smoking or chronic exposure to inhaled irritants, metal particles, dust, organic chemicals, or wood fires. Can be hereditary, caused from a virus, bacteria, immune dysfunction, or idiopathic. Progressive and highly lethal. Once diagnosed, they usually live about 5 years afterward. Excessive wound healing of the lung, creating scarring and fibrosis. This can happen to anybody who has severe lung disease of any type, because like I said earlier, it causes scarring, which causes fibrosis, and that lung tissue no longer works. So we have no area for gas exchange. Eventually, all of that area is gone with chronic illnesses like that of the lung. This thickens the alveoli tissue, making gas exchange very, very difficult. We can't take care of that. We can't heal that. There is no cure for that. Signs and symptoms. Onset is slow with mild dyspnea on exertion. Progression, it is a progressive disease. Patient becomes more dyspneic and hypoxic. Hypoxemia becomes really severe. Rapid and shallow respirations, fatigued, decreased oxygenation, chronic cough, crackles upon auscultation, definitely clubbing of the fingers for them is what you're going to see. If you notice some of the vocabulary in a lot of these respiratory diseases, respirations are always going to be rapid and shallow and high, fast respirations. They're always going to have a low O2 sat. They're always going to have some kind of cough. And the sounds you're going to hear are crackles, other than with pleurisy, that's a friction rub. Asthma, it's going to be wheezing. So a lot of these things, signs and symptoms, are all a lot the same. Treatment is pretty much supportive. We cannot cure this disease. Home oxygen, which will need increasing with progression of the disease. We can give them steroids to help with the inflammation and keep that down. On one of her PowerPoints, she mentions these two. Basically, all that's doing, these two meds here, decreases fibrosis by decreasing growth factors. If we decrease the growth factors, we might decrease some of the fibrin that's causing all of the problem, that's causing the fibrosis. Immunosuppressants, if it's an autoimmune reason that's causing this problem, that means our system is attacking our lungs. Then maybe we can give them an immunosuppressant and decrease how that is attacking our lungs. Definitely flu and pneumonia vaccines. They don't need those secondary infections. Smoking cessation if they're a smoker. Hopefully they're not. Lung transplant is available, and that is the only curative action. The only thing about lung transplant is it's hard to get a lung. It is hard to get a lung transplant. It usually doesn't happen. So this is a death certificate if diagnosed with any type of fibrosis. This one's under pulmonary, but cystic falls under the same category for you. So this just doesn't even sound good for you. The next disease process is atelectasis. You can prevent this. Next problem, if you don't, is pneumonia. They're going to get pneumonia, period, if we don't prevent this. Again, this atelectasis is on us as nurses. This is collapse of alveoli. Anything that decreases deep breathing. Immobility. Once they become immobile, we said that over and over. We want them to cough and deep breathe. Anytime I admit a patient that howls under any of these risk factors, that is the first education I give them. All right, guys, you're not going to be walking and moving around now. I need you to cough and deep breathe. Every time you see a commercial on that television, I want you to take a deep breath in, hold it for 3 seconds, and then release it nice and slowly. And do it as often as you can think of. Let's prevent pneumonia along with a hip fracture. or whatever other reason they might be immobile. Surgery definitely is one with anesthesia. If we don't get to them right away as nurses and make them cough and deep breathe or use their IS, they're going to get atelectasis. Unrelieved pain which causes shallow breathing. And the pain could be from anywhere. If it's an abdominal surgery, a chest tube, it's painful. They do not want to take in a deep breath. As a matter of fact, they hold their breath just a little bit so that they don't have to breathe, because inspiration hurts. So alleviate their pain. Give them their medication to alleviate their pain. And as you alleviate their pain, please make them cough and deep breathe, or they're going to get even sicker. Signs and symptoms are fine crackles heard upon auscultation, the popping sound of the alveoli opening when you ask the patient to take a deep breath. We're going to listen to the lung sounds. So basically, it's when if you take your hair and rub it up against your ear, that's what you're hearing. If you hear that, then it's time for an IS. Okay, treatment basically is cough and deep breathe. Encourage IS use 10 times every hour if possible. Mobilize the patient as soon as possible. Use oxygen initially post-op, and then put patient on to use their incentive spirometer. So make sure you're doing those things for every patient that falls under that risk category. The next thing is obstructive chronic bronchitis and or emphysema and asthma. All three of those fall under obstructive chronic COPD, chronic obstructive disorder, pulmonary disorder. The first one, if you look at the picture that I gave you guys there, the first one is chronic bronchitis. It's the one with the mucus plug. The emphysema doesn't cause mucus, even though they have sputum trapping in there. It doesn't cause the mucus. And so that is how you tell the difference between bronchitis and emphysema, is that mucus plug. And they're bringing up that mucus for you. Where emphysema, on that second picture there, it has to do with the alveoli and air trapping. I mentioned before that our alveoli are grape clusters, beautiful little round grape clusters for enough surface area for gas exchange. On the emphysemic patient, now we have air trapping, which swells up that little wonderful little grape acini and causes what I call, it looks more like broccoli instead of grape clusters. And in that broccoli shaped acini, they have air trapped in there, and they can't get it out of that alveoli. So the patho, I've got it written there: loss of lung elasticity, hyperinflation of the lung, proteases, which is an enzyme, is in higher doses, which damage the alveoli and the small airways, breaking down the elastin, so they no longer have the elasticity for constricting and dilating. This causes the alveolar sacs to lose their elasticity and the small airways to collapse or get narrow. And as you look at the airways themselves, the terminal bronchioles on that photo from normal to the emphysemic, see how narrow they are? They get really narrowed, and that's what makes it hard for them. It doesn't have anything to do with the mucus that the bronchitis person has, but the narrowing of that airway. This is a disease of the alveoli where gas exchange occurs versus chronic bronchitis, which is an airway disease process that causes the trouble. This places the patient in respiratory acidosis because now they're retaining CO2, carbon dioxide, because they are unable to exhale the waste product. They also are unable to take in enough oxygen, making them hypoxic. In the panlobar emphysema, the bronchioli, alveolar duct, and the alveolus are destroyed in central lobular, and I don't think you need to go that deep, guys, in there. Let's look at our risk factors. Cigarette smoking, including exposure to passive smoking, increased age, occupational exposure such as dust and chemicals, indoor and outdoor pollution, genetic abnormalities, including a deficiency of alpha-1 antitrypsin, an enzyme inhibitor that normally counteracts the destruction of the lung tissue. And then these should start making sense to you after going over all these disease processes for us. The chronic cough with sputum production if it's bronchitis, or just a chronic cough if it's cough for the emphysemic patient. Dyspnea during activities eventually will occur at rest. Your COPD patient, especially the emphysemic patient, will have that barrel-shaped chest, weight loss, fatigue, accessory muscle used to breathe when in exacerbation, hypoxia, dyspnea, distended neck veins, pulmonary hypertension, metabolic and respiratory acidosis, cyanosis, enlarged and tender liver. And this, once you get into the enlarged and tender liver, we're in bad shape. Clubbing of the fingers, definitely. Dependent edema starts happening because eventually what happens is we go into heart failure. And so now we're going to start having edema with our heart failure because blood is backing up. Diminished breath sounds when you're listening to the lungs down at the lower bases there. Assessment, and I told you just look at that front page for your assessments because we went through all of that, all these questions that you're going to be asking them. Complications are respiratory insufficiency and failure, pneumonia, chronic atelectasis, pneumothorax due to blebs. Blebs are on your COPD patients. They are just lesions on the lungs that instantaneously pop. They can spontaneously pop, causing a pneumothorax and need a chest tube in there. And it happens a lot more, I believe, with the emphysemic patient over the bronchitis patient. Pulmonary arterial hypertension and right-sided heart failure. And this is just because of everything backing up for them. Labs and diagnostics, we use ABGs a lot with these patients to see, number one, how bad is their CO2 retention? How is therapy working for them? That what we're doing for them, are they getting any better? We want to be careful with your COPD patient with oxygen because they can lose their respiratory drive, because after a while our body's probe that watches out for oxygen levels and CO2 levels, the oxygen part of that doesn't work. They now start living on CO2 levels. If we put them on too much oxygen, we can be lowering their respiratory drive, making it more difficult once we get them back to baseline to continue to breathe, for the brain to tell them, hey, I need you to breathe. And so they have damaged that area by the consistent increase in CO2 levels. So they're used to living with a high CO2 level. But we want to keep them at baseline. One of the things I'm going to tell you is on a test, you don't give them oxygen. In real life, if your patient is dying, you're going to give them oxygen. You're going to titrate that oxygen down as soon as possible as they're getting better and get them back to baseline. But on a test, when it comes to COPD patients, you don't want to give them oxygen, okay? Or increase in oxygen. And usually the answer is not oxygen for your test ones.
Why is it like that on the test?
Because they want you to understand that respiratory drive, that these people are living on the respiratory drive, and we do our best to follow that on the floor. If we're on the floor, not to increase their oxygen. If they are home dependent on 2, we try to keep them on 2 to the best of our ability, but we do increase it initially. When they get pneumonia or something, or an exacerbation, we do increase it, but we are titrating it back down really fast. But the test and NCLEX, and everybody wants you guys to understand as new grads that we can kill their respiratory drive in the brain, part of that, by giving them more oxygen. And so they would much rather you understand.
Okay, so just keep it set at 2.
So you're going to keep it at their baseline that they're used to. And that's why we monitor the ABG on these patients to see what is their baseline CO2. Where is it we want to get them back to? Because that's what their brain is living off of, to tell them to breathe, is that CO2 level. Versus you and I, who don't have COPD, our brain is working off our oxygen level. If our oxygen depletes, it's telling our body, hey, lungs, start breathing some more, bring some in, hyperventilate a little bit, and get some more oxygen in off our oxygen. These people, they're not living off that oxygen drive anymore. They have killed that drive. They are CO2 driven. And so they no longer have that ability to use oxygen as that. So the brain doesn't really recognize that you've increased the oxygen level on these people for them. And so that's the concept that NCLEX wants you to understand for them. Does that make sense?
Oh, okay.
Okay.
Yes, ma'am.
Okay. What else do we do? Okay, so we do ABGs, sputum samples if we can get them for culture and sensitivity if an infection is present. If they are there with a COPD exacerbation, putting them on antibiotics ain't going to help them. That's not their problem. They don't have a bacterial infection. They have an inflammatory problem. And so we need to get them on steroids. WBC, chest x-rays, CT, and sputum analysis, if we can get it. All of those will tell us, WBCs will tell us if it's gone beyond COPD. Now remember, white blood cell count, the immune system, the first response of the immune system is inflammation. So when we have an inflammatory process going on, our white blood cells are going to go up. Neutrophils come out as an army, increasing inflammation. So if I have a white blood cell count of 11 or 12, because normal's 5 to 10, then I have an inflammatory process. I do not have an infection going on. And I don't want to put my patient, you don't want the doctor to put your patient on antibiotics for a WBC of 11 or 12, because that just simply means that they have an inflammatory process going on. And they do. COPDers have an inflammatory process going on all the time. So we have to be careful and make sure we have other signs and symptoms of infection there. Maybe our chest x-ray shows pneumonia. At that point, then we know we have an infection and they need an antibiotic. And you might see their WBCs go up even higher than 11 or 12. Sputum analysis. For initial diagnosis, pulmonary function tests are done. This is done before and after a bronchodilator has been inhaled. Pulmonary function tests are all those tests that we talked about earlier, tidal volume, vital capacity, and all of that. Alpha-1 antitrypsin deficiency test, this kind of is a genetic type thing. If they don't have enough of that, they might be having some lung issues. Medical management. If they're a smoker, if we can help them stop smoking in some format, a nicotine match, a hypnosis, whatever it is that might get them to stop smoking, to send them that way and encourage them for that. Most of them just don't stop and keep going. Bronchodilators, of course, that's your nebulizer treatments with albuterol in them. And so you're going to look at nebulizing them to dilate those bronchioles. Deep breathe and cough, or IS at all times. Increase fluids to decrease the thickness of that sputum. Corticosteroids. If I'm inhaling corticosteroids, we give this to them IV when they're having an exacerbation. But some of them are taking steroids on a daily basis at home as an inhaler. A lovely question they love to ask about this is if you are on albuterol, which is a bronchodilator, and you have to do both, the bronchodilator and the steroid, which one do you want to do first? Does anybody know the answer to that yet? No? Usually the answer is I want to dilate my bronchus so that my steroid can go all the way down. Okay, so I'm going to do the bronchodilator, then I'm going to do the steroid next. It's a question they always like to ask. That way the steroid can go all the way to the bottom to decrease inflammation all the way down. Supplemental oxygen whenever needed. Decrease modifiable risk factors, and this could be obesity, smoking, all of those that are modifiable. Diaphragmatic breathing, pursed lip breathing. I thought I wrote how to do it somewhere in there. I said see above on how to do it. I might have written it somewhere, but I didn't see it. Here's the definition of the different medications that you would use. bronchodilators and what it does, and you guys can kind of read through this because you guys are getting, it's already 7:40. Cholinergic, corticosteroids, leukotriene antagonists, and you guys can read those and see what they do for you. Just remember that when you're giving albuterol, the heart rate goes up. They like to ask that question, so be careful on that one. Short-acting beta-2 adrenergic agonist, and that's going to cause the heart rate to go up. And then all of that is true for both bronchitis and emphysema, noting the few differences between the two. And then I just wrote a little bit of patho down here on bronchitis. Chronic bronchitis is an inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, especially tobacco smoke. The irritant triggers inflammation with vasodilation, congestion, mucosal edema, and bronchospasm. Unlike emphysema, bronchitis affects only the airways rather than the alveoli. There's one of the differences. Emphysema is alveoli. Bronchitis is the bronchi. So remember that. Chronic inflammation causes an increase in the number and size of the mucus glands, which produce large amounts of thick mucus. That's the other difference, is that thick mucus in the bronchitis. The bronchial walls thicken and impair airflow, hindering gas exchange. This decreases the macrophages of the lungs, placing the patient at risk for respiratory infections. To be diagnosed, must have cough and sputum production for at least 3 months in each of 2 consecutive years. Added to above, signs and symptoms are mucus production and productive cough. And then along with everything I'm going to send Hannah is a video on asthma, a 6-minute video that me and my husband created, along with a PowerPoint that's 5 PowerPoints with photos and just a slight explanation along with that. That'll tell you everything you need to know about asthma. And you guys can look at that. For some reason, my picture got cut off there. There's cystic fibrosis. Again, there's that word fibrosis, okay? Whenever you see that, that's just ain't good. Progression, it's progressive. They're not gonna live very long with that diagnosis of fibrosis. Pathophysiology is that this is an inherited fatal disease. This one is inherited. They live now until their 30s. They have gotten better with medications to help support these people. But it basically is a thick, tenacious secretion in the lungs, pancreas, liver, intestine, and reproductive tract. They have increased salt in their sweat glands for this. So you've heard of people licking their babies to see if they have cystic fibrosis because it's so salty. Mutations of the cystic fibrosis gene, which normally transports chloride. And remember, if it's normally transporting chloride, it's also sodium is attached to that because it's always sodium chloride. Must inherit one gene from each parent to have this. Problem is, if one parent has it, they can be carriers and still give that to their child as a carrier gene. And then that person may marry somebody who has the gene also. And then at that point, have a baby with cystic fibrosis. So it definitely has to be each one of those giving that baby that gene, that cystic fibrosis gene. And there's lots of mutations of that gene. Signs and symptoms, a productive cough. It is a bad cough, horrible sounding, wheezing, hyperinflation of the lung fields. They may even have that barrel chest due to the hyperinflation. Chronic respiratory inflammation and infections, difficulty clearing the mucus, because remember that mucus is a great breeding ground for bacteria. If they can't get rid of it, they're going to get some type of infection. Sinusitis and nasal polyps happen for these people. Pancreatic insufficiency. It just affects the pancreas very badly. So the pancreas has to deal with your glucose, insulin, and your digestive enzymes. So because of that, you're going to have vitamin deficiencies, malabsorption. You may even get as bad as affecting the liver for biliary cirrhosis. They get recurrent pancreatitis for them. Diabetes and infertility happens for these people. So it's just a horrible disease process. Diagnostics, genetic testing to begin with, blood immunoreactive trypsinogen, and this is checking for the pancreas. It's also those digestive enzymes it's looking at. The sweat chloride test, it would be elevated in the sweat glands of these patients. And just, I want you to remember that sodium attaches it to it. That's why their sweat glands have sodium in it, because of the excess chloride in there. Chest x-ray shows the hyperinflation of the lungs. GI testing, they're going to look at these enzymes of lipase and amylase. These are the enzymes that tell you if you have pancreatitis also. So they're going to be testing for that. All of those will tell you if you have cystic fibrosis. Medical management, of course, is mostly supportive. Hydration to decrease thickness of mucus. You will get a question somewhere in there to increase fluids to decrease the thickness of mucus. It's got to. Pulmozyme, this is an inhaled nebulized treatment to decrease the thickness, the viscosity, and promotes expectorant of the mucus. So they will do that also. Again, chest physiotherapy to try and position themselves to get rid of the secretions. That is their goal in life, and every day of their life is to get rid of secretions. Inhaled hypertonic saline sometimes will help with that. Antibiotics for any infection. Remember, prevention is the key of infection, so they need to be educated. Stay away from crowds that puts them at high risk for infections. Hand hygiene really well. They kind of stay in a bubble pretty much. So we're educating them about how to prevent any type of infection. Supplements, they need to take in their fat-soluble supplements because of the malabsorption of the foods, because that's where we get our fat-soluble vitamins. Bronchodilators and, of course, steroids, again, to dilate the bronchi and decrease inflammation. Digestive enzyme replacement, pancrease and biocase, those are different ones to replace those digestive enzymes that are not working in the pancreas. Only thing that can help them is a lung transplant. And again, those are very difficult to get and qualify for. And that's everything on cystic fibrosis. Pulmonary embolism, you're going to see this a lot. Pathophysiology, basically it's an obstruction of the pulmonary artery or one of its branches by a thrombus, by a clot. There are different risk factors down there, which I'll read in a minute, but a thrombus or a DVT, deep vein thrombosis, which originates either in a vein, in the lower extremity or right side of the heart, maybe. There's a dysrhythmia called atrial fib, which really puts them at high risk for thrombus. The clot can also come from a central or peripheral line. If that line clots off and you go to flush that line and push that clot off that line, guess what? You may have given your patient a PE. So you got to be very careful that if you have any resistance when you're flushing those IV lines, not to push too hard because it's clotted off and they need a new line. A fat embolus from a fracture, any type of fracture, especially of the long bones, are high risk for clots. I have seen a lot of people come in with PEs 3 to 4 weeks later after their surgical issue with their, whether it's the hip from the femur bone or knee surgery, and they've got a pulmonary embolism due to that surgery. So they're at high risk for those. Risk factors, of course, is any trauma can cause clotting off and cause it to embolize. Surgery, definitely surgery, especially any type of surgery that has to do orthopedic wise. Those are really at high risk. Any pacing wires within the heart or any foreign object at all. Think about anything. Our body doesn't like it. So it's going to clot it off and try and get rid of it. So stents in the heart, when they do that, or in the lower extremities, we put stents in for people with peripheral vascular disease, with peripheral arterial disease, to get blood flowing again because they're stenosed, they're narrowed. So They're foreign objects. Our body doesn't like foreign objects, so it wants to get rid of it. Mechanical valves, when they have a valve replacement and it happens to be one of the mechanical ones, it's a foreign object. Body wants to get rid of it. So it clots around it, and clots can embolize. This is why these people need to be anticoagulated immediately after their procedures, and they will stay on anticoagulants for the rest of their life to prevent a clot from embolizing. Central venous catheters, these are at high risk for that because they'll clot around the opening of where that central line is placed. They're put into the subclavian, which is right near to the heart, and it's just going to go right there into the heart or into the lungs. Signs and symptoms, they're going to have a sharp, severe substernal, pleuritic, or epigastric pain, and it is an immediate sharp pain. Increases with inspiration. It does mimic an MI, so it can be the same feeling. They're going to be short of breath, dyspnea, and it's going to be a painful short of breath. Tachycardia, their heart rate is going to immediately go up. It's going to hit the 120s, 130s. Tachypnea, respirations anywhere from 25, 26 to 30, even higher at times, depending on how bad that pulmonary embolism is. They're going to be coughing, trying to get up, whatever it is that's causing the problem, and they're not going to be able to get anything up, but they will have a cough. They're going to be apprehensive because they're going to have what we call air hunger. They can't get air in, and they are desperate, and so they become anxious and apprehensive, and they think they are going to die, which they can die from a pulmonary embolism, depending on the size of that embolism. Diaphoresis, because now we've entered into the sympathetic side of life, and now I'm going to start sweating. Hemoptysis, they could start coughing off blood, and it can be as bad as syncope, where they faint because they don't got enough oxygen to the brain on them. So this is a very dangerous thing, pulmonary embolisms, and so we need to monitor for that with anybody who is high risk at that. There are people out there even, and I didn't write this down, disease processes that have that make way too much clotting, that clot off way too much. Leiden 5, factor Leiden 5 disease, what's the other one? William Vaughan something disease. These people have clotting issues, and so they are on anticoagulants, period. As a matter of fact, I just had a patient this weekend who had a stroke from a clot because he went to the dentist. He has chronic atrial fib, the dysrhythmia. And that can be added under risk factors if you want to, is atrial fibrillation. He got off his Pradaxa, which is an antiplatelet, a few days before a dental procedure, and they didn't put him on anything else, and went for his dental procedure. 3 days later, he had a stroke from a pulmonary embolism because of the AFib. They cannot come off those anticoagulants. They need to stay on those anticoagulants and be educated to stay on them. So it was a bad stroke too. Diagnostics, how are we going to diagnose this? A chest x-ray, we're going to do an ECG, a D-dimer, that is a key, and you want to highlight that if you want to, is that D-dimer is a fibrinogen activating test, and it shows that the fibrinogen is high and elevated, meaning that they're making clots somewhere in there. So if it's elevated, and they usually will do that, anybody coming into the ER short of breath with chest pain, that's one of the lab tests. It's just plain and simple that they do, is a D-dimer, and if it comes back elevated, the next place they're sending that patient is in for a CT angiogram. And so they go in, and that CT angiogram shows that pulmonary embolism. That's why they're having chest pain. That's why they're having increased heart rate and shortness of breath. So that keys the MD into sending them into further testing. VQ scan, CTA scan, and an ABG to show us how bad their hypoxemia is. ABG basically tells us that. Our goal is to prevent this. If we put people at risk for this, I need to add that to that note. To avoid venous stasis, anywhere that a patient is pulling blood, take an immobilized patient. Where's the blood going? It's going down and staying down. Think about the calves of our legs where deep vein thrombosis is, where they like to build up at, is because the blood is pulling at the back of the leg there and it's not moving up. Remember, the venous system is what pulls our blood back to the heart. When the venous system is not moving because it has valves in it and it needs gravity and it needs exercise, movement to make it work and flow and bring that up. As soon as I immobilize that patient, they begin to have what we call venous stasis, meaning blood pulling in the venous system, in the veins. And anytime it settles down and it isn't moving, it's going to clot and it's going to create a deep vein thrombosis on them. So we want to prevent that for these patients. And the way we do that is active leg exercises, meaning they're doing push-pulls with their feet all the time and educating them. Okay, you're immobile, but you can sure move your feet. Pedal like you're riding a bicycle or do something like you're driving a car. But moving that blood back and forth so we can go back up to the heart. If they're immobile, we're going to mobilize them as soon as possible. We're going to put anti-embolism stockings on them, or what I call SCDs, sequential compression devices that are going to massage that blood and move that blood up so that we can prevent any type of DVT, any venous stasis, anything from blood being pulling at that bottom of that leg. That's why it's really important to put those on. Anticoagulants for high-risk patients there, and I gave you a list of that and a list of the different types of anticoagulants that we use. We definitely put them on Lovenox or heparin. Those are the two main ones we use in the hospital. But if they fall into one of these other categories of high risk and need to go home with something, they're going to be on aspirin, warfarin, or Eliquis, Pradaxa, Xarelto. Sometimes I see them on aspirin and Pradaxa. Sometimes I see them on two anticoagulants, just because they're so high risk for clotting. But they need to be on that. Medical management, if it happens in the hospital to you and you're suspecting a pulmonary embolism, first thing you want to do is get oxygen. Get that head of the bed up, put that oxygen on them to decrease that heart rate and give them some oxygen, decrease the hypoxemia. Get some anticoagulation therapy on them immediately if they have not been on it. They're going to be on that for at least 6 months to a year if this is the first time this happens to them. Thrombolytics, if not contraindicated, you don't see a lot. This is TPA. This is different. A thrombolytic is different than all of these medications that I spoke about above here. A thrombolytic is what we call a clot buster. It actually breaks up the clot. These other medications don't break up the clot. They just decrease, they just cause it not to get bigger. Our bodies resolve the clot within itself. And it takes 6 months to a year for that to happen. So we put them on those blood thinners to prevent it from growing and getting bigger. But the thrombolytics now is different. These actually break up the clots, but it's not used a whole lot for PEs. It's used more for strokes. If a clot caused a stroke, then we're going to use a thrombolytic if it is not contraindicated. And there is a long list of reasons not to do this on people. If they're on an anticoagulant, they're not going to do it. If they have had any trauma or any recent surgery to the area that they want to do this thrombolytic stuff. So many other things that they have to ask them before they decide to do that, because if they do decide to give them a thrombolytic, which is known as TPA, it's going to break up every clot in their body, not just that one, but every clot in their body, which puts them at high risk for bleeding out. So we really got to be careful on giving those. These patients are not on the floor if we're giving a thrombolytic for them. So we don't use that too much for PEs. Surgical placement of a filter, that I do see a lot of. The filter can be in either place. They can be way up here above the aorta or at the abdominal aorta down below. And what this will do is if they are at high risk for clotting and they're throwing a bunch of clots, they'll put that filter to catch that clot for that. And so that's a surgical procedure, and it does help a lot of those patients, and it prevents pulmonary embolism, prevents heart attacks for them. If it's up above here, it's trying to prevent strokes above the heart. So that is a wonderful thing that they have found out that helps a lot for them. The next thing is pneumothorax. Air breaches the pleura surrounding the lungs, causing the lung to collapse. This is very, very dangerous. It can be these 3 different types: simple or spontaneous pneumothorax, rupture of a bleb. Think about your emphysemic patient that I talked about earlier. Air breaches either the parietal or visceral pleura, enters and exits. That air is going in and out. She's got great pictures on her PowerPoints of this. Traumatic pneumothorax, laceration of the lung, wound in the chest, rib fractures causes this. So any type of trauma, knife stabbing or anything like that will cause this type of pneumothorax. They can, a thoracentesis, if they accidentally puncture past that first layer to get that fluid out, can cause a thoracentesis and a collapse of that lung. Insertion of a subclavian central line when they're putting that in, because it's a guide wire that's putting that in. So they can accidentally puncture it and cause a pneumothorax. A tension pneumothorax is where air upon inspiration cannot exit the lung and is trapped. And so now it's starting to build up with every breath that they take, and it's causing collapse of the lung. So it just keeps pushing on that lung and collapsing that lung for us. This is the one, it's the tension pneumothorax that you can see the trachea deviate over to the affected side. And you can see that really plainly. Signs and symptoms is sudden pain. If small or simple, signs and symptoms are slight discomfort with some tachypnea, but if large and total collapse, the patient is anxious, dyspnea, shallow rapid breathing, they're having air hunger, increased accessory muscle use with asymmetrical chest expansion, absent breath sounds on the affected side, central cyanosis from severe hypoxemia, tracheal deviation, bradycardia, shock and death if untreated. Diagnostics are chest x-ray, ultrasound, ABGs. With medical management, goal is to evacuate the air of blood from the pleural space. The chest tube is inserted and suction is applied. And you can kind of see her PowerPoint on chapter 29 regarding chest tubes. But here's some key points that you need to kind of look at. Verify all connection tubes are patent and connected securely. Assess that the water seal is intact when using a wet suction. Monitor characteristics of drainage, color, amount, consistency. Assess significant increases and decreases in drainage. Keep system below the patient's chest. Assess suction chamber for bubbling and wet suction systems. Maintain appropriate fluid and water seal in wet systems. Keep air vent open when suction is off. So those are things you're monitoring as a nurse when it comes to a chest tube, and also put that together with the rest of her PowerPoint that she has for you. Then we're going into, I should be on my last page here, rib fractures. Only thing that can be done is to control the pain with analgesics. There's nothing we can do with rib fractures other than help them support it with pain. Make sure patient is coughing, deep breathing to prevent pneumonia. So we're going to prevent any complications of pneumonia for them. Flail chest, another complication of blunt chest trauma, meaning 3 or more adjacent ribs are fractured or 2 or more sites, resulting in a free floating rib. So that whole rib cage is just kind of floating inside the chest wall. During inspiration, the chest expands and the detached part pulls inward. Thus, we have a flail chest, meaning that symmetry is no longer there. It's kind of in and out on those sides, right and left. Supportive care treatment like the rib fractures is what we're going to do for them. Then I went into acute respiratory failure. Either the ventilation or perfusion mechanisms are impaired central nervous system, This has happened from drug overdose, head traumas, infection, hemorrhage, or sleep apnea, looking at anything that might cause hypoventilation. The head trauma, because you've hit the respiratory part that tells me to breathe, tells the lungs to take that inspiration. Infection is preventing it. There's a lot of bacteria in the lungs that doesn't allow you to ventilate very well. Bleeding will also do that. And then, of course, sleep apnea is obstructive. The drug overdose, meaning, again, I've shut down my brain enough to tell me to breathe. So those are all possibilities of why acute respiratory failure can happen due to ventilation or perfusion. Those are more ventilation. There's neuromuscular dysfunction. Maybe they have a disease process like myasthenia gravis or ALS or spinal cord injuries. All of these are nervous. The nerves are damaged in the muscles. So we can't use our muscles very well in all these diseases. In spinal cord injuries, we can't even feel our muscles below the waist, below the injury. And so if their spinal cord injury is above the lungs, now I can't feel those muscles in my lungs. So these people are usually on some type of trach with oxygen or ventilator for them at this point. Musculoskeletal, chest trauma, kyphosis, malnutrition. Again, all of these does not allow me to ventilate the way I need to appropriately. Maybe you have a pulmonary dysfunction or disease process like COPD, asthma, cystic fibrosis, chronic versus acute. Understand that. So these are more slowly happening for these patients on them, meaning these are chronic disease processes that are progressively going to put them into respiratory failure for that. Signs and symptoms: impaired oxygenation, restlessness, air hunger, tachycardia, increased blood pressure, confusion, lethargy, diaphoresis, tachypnea, and decreased breath sounds. All of these are, by now, you've heard these over and over when it comes to the respiratory system from me, that are going to cause some kind of respiratory failure. If you go in and your patient's O2 sat keeps dropping and you're having to increase the oxygen for them to keep them above 92 degrees, there's something wrong. It's time to call for help. The first people I call is respiratory therapy. Come and evaluate my patient. Why am I having to increase their oxygen? They will come in and evaluate your patient for you, and they will help you think about what's going on and whether or not you need to call a rapid response on this patient. Maybe they do need to be intubated at that point. So really monitor how often you're having to increase that patient's oxygenation because they're going to start having all of these issues in here. Anybody who has a respiratory problem has a high heart rate because the heart is trying to compensate by giving them more blood. If I give you more blood, maybe I can give you more oxygen. It doesn't work that way. When you do cardio, I can explain that later. But that's what the heart is thinking. So the heart rate is going to always go up. And if you have a COPD patient, their resting heart rate is anywhere between 95 and 110 all the time for them. So if they're in respiratory failure, their heart rate's even going to be higher. Lethargy, because they're not getting any oxygen to the brain anymore. So remember those for all of these guys. Treatment, treat underlying cause. What is causing this respiratory failure? There are many, many reasons, as you can see above, that can put you into a respiratory failure. May need endotracheal intubation and mechanical ventilation. Assess respiratory status, monitor level of consciousness, ABGs, always ABGs to help monitor their PaO2. Anything below 60, you are in respiratory distress. So you need something done immediately on that ABG. Vital signs, of course, If your patient happens to be intubated or on mechanical ventilation, you want to make sure that you do oral care every 2 hours. They really need that done. Skin care, looking at their skin, turning your patient, range of motion so they don't get contractions, and turning your patient so that they don't get any bed sores on them. So make sure you're taking care of your patient if you're in that area. That's where I stopped with my notes because I've been working all weekend. To get this, the only thing left that's on your PowerPoints is lung cancer, I believe. And as you look at her PowerPoints, look back at this acute respiratory failure, because eventually that's going to happen. She wants you to look at lung cancer with regarding the surgeries that they can do, lobectomy or a pneumonectomy, where they take out the lobe. It eventually, if they have a localized area of cancer, they'll take out a lobe, which is what happened to my mother-in-law. They took out a lobe for her, and she went many, many years without cancer, several years afterward, because that is a curative way of getting rid of that cancer. She did not have to have chemo. She did not have to have radiation or anything. They just went right in and pulled out that lobe. And it did cure her for the longest time until the last year of her life. She began having the signs and symptoms of respiratory failure here. Increased respiration, short of breath, restlessness, decreased breath sounds. And when she finally allowed me to take her to the doctor, they did a thoracentesis. I admitted her, did the first thoracentesis of her, and sent out that exudate because it just fills with nasty purulent fluid inside the lungs from this cancer, and they got to get it out, and it's in the pleural space. It's not inside the lung itself, and so they pull it out and they send it for testing, and it came back malignant for cancer, lung cancer. So she describes 4 different types of lung cancer that you can get in there. Don't go in depth, guys. She's not trying to make you a cancer nurse. She is not trying to do that. What you need to realize is, how would you see your patient, the signs and symptoms, okay? In every one of these, realize what your patient will look like. What would you do first off if something was to happen? What would be the first thing you want to do? You want to get them to breathe. You're going to put the head of the bed up. You're going to give them some oxygen. You're going to call for help. Look for something that is different in every one of these disease processes, because they're all similar in signs and symptoms. They're all have many of the same tests, diagnostic tests for you. So the only difference, it may be, it's in the treatment, on how we treat these patients. But she's really going to, I believe, test you guys on signs and symptoms, maybe even some delegation questions. Remember, when you're doing delegation questions, you're giving it to a certified nurse's aide. She's not licensed. So if you're going to delegate something to a CNA in a question, that whatever a CNA can do must mean that evidence-based practice is not going to change the way it's done. Evidence-based practice is not going to change the way I ambulate a patient. Evidence-based practice is not going to change the way I do my vital signs. They might get a fancier machine, but it's always going to take, the blood pressure cuff, a stethoscope to do a blood pressure, thermometer to take the temperature. Those things are not going to change no matter what happens throughout the years. So unchanging procedures can be given to the CNA. If you can remember that when you're answering delegation questions, then you guys will start getting those correct if you're having trouble with those type of questions. If you look at a question and you don't know the answer, take a deep breath, slow down, and look at the answers. Look at all 4 answers. If there is a mixture of assessments and implementations, okay, meaning actions, something I have to do or something I have to assess, go back to the question and see if an assessment's already been done. If an assessment has already been done in that question, kick out all the assessments, no matter how good they sound to you. because the assessment's done. It's time to implement. It's time to do something, leaving you with just the implementation answers. And your choices need to come from those implementation. Then you're going to look at, okay, what makes sense in this question to answer those questions. So try looking at it that way. Always use Maslow's ABC, okay? What comes first? The physiologic comes first, okay? Anything physiological must come first. Anything psychosocial is second. We're not even going to use it. We need to take care of the physiological first. When
Miss Patterson,
say that again, honey.
Miss Patterson, can you hear me? You can? Okay. So you said on those questions where it was asking apply O2 and then raise the head of the bed, you said always go with raise the head of the bed first.
Hang on, I can barely hear you. Let me see if I can increase the speaker sound. Ask me again, honey.
Okay, you know where you, earlier you said we might have a question about either raise the head of the bed or apply O2, and
Yeah.
you said go with raise the head of the bed first.
Yes. Yes.
Okay. Thank you.
You're welcome. I can't think of anything else, but this, you got to get your patient breathing, okay? Use your knowledge to be able to do that. I am going to put the recording. I will put the stuff for asthma in there. It'll take you 5-6 minutes to go through what I have for asthma. And it's pretty self-explanatory with the video. And I'm hoping I can get all that to Hannah tonight. Once this recording has finished recording and they send me the link, I will send that to Hannah so that she can get that out to everybody. But try not to go so far in depth in your studies because that's not what they want from you. Most professors want, do you know what your patient looks like? Do you know what you're going to do for them? As a nurse, and what your scope of practice is. And understanding if you're giving some type of test, is there anything you have to do for that patient? Do they need to be NPO? Do they need to be, what is it that is required for me from that test? And these tests for these guys isn't much. You know, chest x-rays, ABGs, CT scans on all of that. So there's not a whole lot that you have to do as a nurse. You just got to make sure they got a good IV for the CT scan for them and go on from there. What else can I encourage you guys with? Do you guys have any questions or concerns that you're worried about? No?
No, I appreciate you doing this video though.
You're welcome.
Yeah, I really appreciate this video.
I
I
hope
feel a little better about this test Wednesday.
do you?
Me too.
Let me know how to assess your patient, okay?
Mhm.
For this, so.
Right.
Okay, because this is a lot of stuff. There's no way you can remember every single thing about
Oh,
these
yeah.
processes. Okay, you're going to have to critically think it through, and so hopefully this helps. Okay. All right, guys.
Yes, ma'am. I appreciate it.
You're welcome.
Thank you.
Guys, on Wednesday, I guess. Okay. All right, I'm going to end this.
All righty.